We will now start the online event on status epilepticus. Good afternoon to you all. The Danish Society of Clinical Neurophysiology would like to welcome you to this online event. My name is Martin Ballegaard. I'm the chair of the society, and I will introduce you to our program and our panel. Before starting the online event, I will just give a message to our Danish members and ask them to join us at our 2021 annual meeting this year with your physical presence at Haraldskær, November 5th to November 6th. This is our program for today. As you saw before, we will start with the introduction, and then we have a fascinating program for you. We will cover both fundamentals and state-of-the-art concepts about status epilepticus. From the clinical evaluation over EEG features and status classification to treatment paradigms. We are sure this event will benefit all clinicians who care for critical ill patients in the emergency room, in the neurology ward, and in the neuro ICU. Reflecting this need, we have more than 600 Danish and international participants joining us today. Thank you all for supporting this event. Our four invited speakers all have 45 minutes to their disposal. In order to keep a strict time schedule, I will give the speaker a notice 5 minutes before the end of their talk. We will have a 15-minute time slot for question and answers, so please write your question in the Q&A dialogue during the talk. We will post the questions to the speaker. Sela, you had some practical info too?
Hello, everybody. Okay, Isila is not here at this time, but my name is Peter. My colleague and I will be the online moderators of this meeting. And we have some practical information. First, as Martin just said, we kind of ask you to write your questions in the Q&A function below. And during each talk, we will collect the incoming questions. Similar questions will be grouped. And at the end of each talk, we will read them out, and the speakers will try to answer. The speakers will answer as many questions as possible during a 15-minute Q&A slot following each talk. We would also like to inform you that because of the huge interest in this meeting and the limited number of participants allowed by the webinar, we are streaming this whole session in a YouTube channel. The session will be recorded and will be available online at the Danish Society homepage for a couple of months. I think that will be all. And Martin, I will give back the stage to you for introducing the speakers.
Thank you very much. I will give a short introduction to each of the four speakers, and after this we will start the sessions. We have been lucky to get very prominent speakers who are epileptologists, each focusing on their topic today. First, Professor Eugen Trinker from the Christian Doppler Clinic in Salzburg, Austria, will take us through the definition and classification of status epilepticus. Second, Professor Sander Benitsky will talk about how EEG is used in the diagnosis of status epilepticus and how it could help in guiding the clinical management of the patient. Third, Professor Lawrence Hirsch will help us getting the EEG terminology right now in its latest version from this year. Through the use of common terminology, we will have the right context to choose between treatment options in the critical ill patient. Last, we will ask Professor Jakob Christensen to help us use the information we just heard about in order to choosing the right treatment for status epilepticus after the initial treatment has proven non-effective. So now I will ask Professor Eugen Trinker to take the stage.
The cyberspace is mine, okay.
All right. But the Russians will say something about that.
So, Rizela, Jakob, Shandor, tell me when we are now on air.
You are on air, Dr. Trinker.
Good, you sound wonderful with a big echo, so I think the audience is in the whole universe. Let me welcome you cordially, ladies and gentlemen, dear colleagues, dear friends in Denmark and all over the world. So the talk here is definition and classification of status epilepticus, and I was asked to give an overview, and other talks later go into the depth of classification by EEG criteria, and also of treatment and terminology, how to talk about EEG signals. These are my disclosures. Let me give you some key facts about status epilepticus. It's a frequent neurological emergency. 4.5 million status per year in the world, and the incidence of the first episode is around 36 per 100,000 adults per year, but it increases steeply over the age of 60 to 80, 90 in women per 100,000 per year. So at this incidence, it's no longer a rare disease. You know, the limit for rare diseases is 50 per 100,000 per year as a prevalence. So this is incidence rates. And the refractory status, which is a therapeutic problem, and you will hear Jakob Christensen's talk about this, is 7.2 per 100,000, and super refractory is even rarer. So in a small city, it's about once a year. Mortality rate is high. Pooled mortality ratios in adults is 15–16%, and the refractory goes up to 38%, with no decrease over time despite our treatment. Less than half have pre-existing epilepsy, low anti-epileptic drug levels, acute symptomatic causes are prevailing, cerebrovascular, traumatic brain injury, encephalitis, meningitis, alcohol-related, and metabolic. These are the big 5 or 6, depending how you count. There is consensus in the community that status epilepticus is a special condition and not just a longer seizure. Overview about definition, classification. There is some things about the pathophysiological framework. It's important why we have this classification, and there are some clinical implications. I will just go through the stage treatment very quickly because there is a dedicated talk towards the refractory treatments. So the definitions of status go back to the 19th century. The first work around 1824 by Calmet coined the term état de mal, and then it was translated into English Latinized language, status epilepticus. The gentleman on the right is Henri Gaston, and he said that there are as many types of status as there are types of seizures. And that was 1960. The definition further evolved, and then the ILE defined it as a seizure that persists for a sufficient length of time or is repeated frequently enough that recovery between the attacks does not occur. So then it became clear that the majority of generalized tonic-clonic seizures don't last longer than 3 minutes. So then Lowenstein came up with the operational definition of 5 minutes. Everything which is longer should be status. And in the non-convulsive forms, that's a bit of a problem because they left it completely out of the classification at that time. And I like especially the definition by Frank Grislane. He said that non-convulsive status is an enduring epileptic condition with reduced or altered consciousness, behavioral and vegetative abnormalities, or merely subjective symptoms without major convulsive movements. So the traditional definition was at least half an hour. It was based on, assessment, but not on scientific rules. And we now set the time for 10 minutes. So the definition now was put forward by this group in 2015 and had integrated 2 operational dimensions. So it had a conceptual, mechanistic definition with these 2 dimensions. One is the length of seizure, T1, and the other one is the time to long-term consequences. So status epilepticus is a condition resulting either from the failure of mechanisms responsible for seizure termination or from the initiation of mechanisms which lead to abnormally prolonged seizures after time point T1. It is a condition which can have long-term consequences after time point T2, including neuronal death, neuronal injury, and alteration of networks, depending on the type and duration of seizures. So in blue are the operational dimensions, T1 and T2, and in red is the concept behind it, that there is a failure of mechanisms leading to this abnormally prolonged. The whole thing, why we define it, is about avoiding and preventing the long-term consequences which appear at time point T2. There's a myriad of sequences going on. They are not only related to the brain damage, but there are also systemic changes leading to respiratory acidosis. Continuous seizure activity leads to a high metabolic demand, O2 and glucose consumption. The brain follows and answers with a hyperperfusion. There is disruption of blood-brain barrier and the vasogenic edema, which can be visualized by MRI. Then there is a shift to anaerobic metabolism if the metabolic demand exceeds hyperperfusion. Lactate accumulates, there's a failure of sodium-potassium pumps, water and sodium influx, and cytotoxic edema, which can also be visualized by MRI. And there is a point of no return. If status is stopped at that point, there is reversion of neuronal damages. But if the status is not stopped, there is highly likely there is irreversible neuronal damage and long-term consequences, which we also see now in the MRI, and this is what we want to avoid. As I said, please don't forget the systemic consequences: metabolic acidosis, lactate accumulation, hyperthermia, electrolyte disturbance, hypoventilation, again leading to respiratory acidosis, hypoxia, and these patients are in catecholaminergic storm. They are hypertensive and then later hypotensive. There may be acute cardiac failure, arrhythmia, and capillary leak leads to multi-organ failure. This is why the patients die. The whole thing with T1 and T2 depicted in another way. We have non-convulsive status proper with and without coma. For example, focal status with impairment of consciousness lasting longer than 10 minutes at T1, and T2 we expect at 1 hour earliest. Absence status also 10 to 15 minutes is T1, but T2 is completely unknown. And the important point is the comatose non-convulsive status epilepticus, which evolves from a generalized tonic-clonic status epilepticus most often. T1 is at 5 minutes, motor phenomena decrease, and T2 is at 30 minutes ongoing convulsive activity. The patients have no longer motor activities as prominent feature, but they are in coma, and this is the so-called non-convulsive status. This is from our epidemiological work, which I already quoted. So it's 79 per 100,000 per year in the elderly group, 60 plus, and it's astonishingly much higher in women than in men, and that's an exception from the rule that men have a worse health than women. And there is a steep increase going up to 200 per 100,000 per year in the age group 90 plus. During the COVID pandemic in Salzburg last year, we looked at the incidences from our area, the total admissions, and Salzburg city inhabitants, and there was no increase or no decrease during the pandemic, which is kind of reassuring that these people are still coming to the hospital. And there is, of course, a different situation in stroke and in oncology where people stayed away from hospital. Refractory, there are two studies, one from Salzburg and one from Finland, which was published earlier. The incidence rates are very similar. It's 7.2 per 100,000 for refractory, and in Finland 3.4. And super refractory, it's 1.2 and 0.74 per 100,000 in this range. So the confidence intervals are overlapping, and I think that gives you a good estimate of how often this occurs. A little bit different the situation in children. The overall incidence is lower, 16 per 100,000. Most of them are non-refractory, and the incidence peaks in the first year of age, which accounts for 48% of all pediatric super-refractory cases. So that's an important message. These are the very early causes, but the majority have a good outcome. As you see, green is home discharge, and here in super-refractory, 11% of the children die. The classification consists of 4 axes. Axis 1, semiology, etiology, EEG, Shander-Binitsky will talk about that, and age. And these 4 axes overall make the classification based on the assumption that these are clinical entities or specific conditions. The group number 1 is the one with prominent motor symptoms. The most important, the convulsive status, can be generalized, can be focal onset with evolving into bilateral convulsive or of unknown onset. Then you have myoclonic with coma or without coma. Then you have focal motor, where motor phenomena are the only symptom, can be EPC, aversive status, oculoclonic status, or it can be ictal paresis, also prominent motor symptoms, tonic status, and hyperkinetic status. These are opposed to the ones without prominent motor symptoms, the non-convulsive forms. They can occur with coma and without coma. This is the second taxonomic criterion, motor phenomena and level of consciousness. Generalized non-convulsive are the absence status, atypical absence, and myoclonic absence. Focal are the ones with impairment of consciousness and without impairment of consciousness. And there is, of course, unknown group, which is the autonomic status epilepticus. These are the non-convulsive forms. So is this intellectual gymnastics, or is it part of the real world? And one thing is that we look at the case fatalities, which is CF here. In the study, which we performed with the epidemiology, we clearly find that there are bad status types. These are the ones without prominent motor phenomena, with impaired consciousness, somnolence, super, coma, 40% case fatality. And the ones which evolve from prominent motor symptoms into non-convulsive with coma. These are the most severe forms. The moment you have only convulsive phenomena on the left side here, case fatality is 0. So when we see a lot of motor phenomena, it's not the worst case, but when the patient turns into or moves into coma, these are the ones which are impaired. So the consequence is that the outcome of status is associated with its semiology, according to our classification, and the worst outcome is in non-convulsive with impaired consciousness. The dynamics of convulsive status into comatose is a poor prognostic sign, and there is good outcome in status without impairment of consciousness and in those where only motor phenomena are present. EEG is something which the next probably 3 talks will deal about. These are EEG criteria for non-convulsive status epilepticus, but please, whatever Sándor Benitsky tells you and teaches you after that, please rest assured clinical data are extremely important to interpret that. And I don't go into detail, I just want to let you know that the border which we defined in our joint paper is 2.5 hertz. And the reason for that is that everything which is increasing in frequency above 1 to 2 hertz has a higher metabolic demand. And there's a nice study from Aaron Strock's group and Andy Cole. It shows that there's a linear increase in metabolic demand when you have periodic discharges at a certain frequency. Etiology, axis 2, divided into symptomatic and cryptogenic, and the symptomatic can be acute, extremely important to find the cause, remote, also extremely important to distinguish it from the acute, and progressive symptomatic, which is equally important as the first 2 ones. And then, of course, for the epileptologist, there are status in defined electroclinical symptoms, for example, or syndromes, for example, the absence status epilepsy. But there is an important group, it's the cryptogenic or unknown group. Cryptogenic and unknown is synonymous. The preferred term by the Anglo-American literature is unknown. 26% of the super-refractory status is unknown. The cause is unknown. And the other ones, they distinguish by certain rare diseases. Some of them are common, but there is an important message here. New onset super-refractory status is a clinical presentation in a patient without active epilepsy or other pre-existing relevant neurological disorder with new onset refractory status without a clear acute or active structural toxic or metabolic cause, which can be identified in 72 hours. That was a consensus paper led by Larry Hirsch, who really moved the field in that aspect. And 72 hours is quite long. So you should have the big 5, which I mentioned you before, within the first few hours. But then, of course, you have some time until these tests come in, autoimmune antibodies, paraneoplastic markers, or infections. And if you do all these laboratory tests, this can elucidate around half of the patients. So it's 19 plus 18 plus 8 is around 50%, which can be explained by these rare causes. And there is, of course, a poor outcome with 22% mortality in this series, quoting Larry Hirsch and Tobias Lodenkemper and Sarah Hocker's group, Nicolas Gaspard and Tenel Gofton. So we should look for the causes very deeply and treat them. Treat them with immune modulators, as you see here. That's just an outlook of what comes later. And there are some strategies. Number 1, identify and treat the cause. That's important. Number 2 is early treatment to prevent the long-term consequences. And as I said previously, there is a cascade of events. And this very nice graph by Beitjeman and Löwenstein showed that you have early changes with protein phosphorylation neurotransmitter release, and you have also later changes, with receptor trafficking, neuropeptide expression, and genetic changes. In the early phase, GABAergic treatment makes sense, and in the later stages, other mechanisms of action seems to be a good choice. But we may also think about early treatment with 2 anti-epileptic drugs, different modes of action. There are now studies planned, and what is important, these mechanisms relate to the convulsive status and comatose non-convulsive, and it may be completely different in absent status or EPC, or in childhood encephalopathy. So we are not sure about that. How does it relate to the other status types? Strategy number 3 is stage treatment approach tailored to the pathophysiological changes. And you all know this staged approach: early, established, refractory, super refractory, and the drugs on the right hand, benzodiazepines, anti-epileptic drugs, and later anesthetics. And then it's, of course, an evidence-free land. And Jakob Christensen is trying to elucidate this area, which is extremely important because, as I explained, the mortality is high. But if you do something wrong in the beginning, it's also a critical point. And this comes from our SENSE registry led by Christoph Kellinghaus, looking at status epilepticus in the early phase, but also observing it to the late phase, 1,049 incident episodes. And the key message of this slide is that the bolus doses were lower than recommended by current guidelines in 76% of convulsive status and 78% of non-convulsive status. So that's enormous. 75% are underdosed. So even in a country like Germany, Austria, and Switzerland, where you think you are top-notch, and no, it's not the case, underdosing is the case. First step treatment, very important that benzodiazepines are better than anything else. Here is the cumulative probability of having the patient still in status after 1 hour on the left and after 12 hours on the right. And you see, if you use levetiracetam only, there's a 90% probability that the patients are not out of status after 1 hour, and still 60% are in status after 12 hours. But if you use benzos, they are very similar in their response rate. But as I said, underdosing leads to a lower response rate. This is between 60 and 80%. This is between 20 and 40% response rate in the first hour, and between 40 and 60% response rate. And we know from randomized controlled trial that about 60 to 70% are controlled when you give the right dose, which is used in the randomized controlled trials. We have 4 anti-epileptic drugs, and now we have the 5th one with lacosamide. We have the 6th one with brivaracetam, and we will soon have the 7th one with perampanel IV, not on the market yet. These drugs differ, of course, in terms of their efficacy, probably. The ESET trial tried to find a difference between phosphonitoin, valproic acid, and levetiracetam. Extraordinary design, excellent group. These are the results, no difference. The pre-specified stopping rule for futility of finding one drug to be superior, inferior, was at an interim analysis at 140 patients. Response rate in the second stage of treatment is around 50%. It's astonishingly similar between these 3 drugs. So you can choose whatever you want. Also, the life-threatening hypotension within 1 hour after start of infusion was slightly higher with phosphonitoin, but there was no statistical significant difference. Another study in children looked at phenytoin versus levetiracetam. Key message, no difference. Levetiracetam is not superior to phenytoin. A third trial, also published in the Lancet 2090, again, phenytoin versus levetiracetam. Key message, no difference between those two drugs, or other words, levetiracetam was not significantly superior to phenytoin. As I mentioned, lacosamide was not included. This is from our friend Adam Stelchik. 500 episodes, success rate 57%. So it would be worthwhile to look at the efficacy and tolerability of lacosamide. But another thing which really thrilled me is an indirect comparison by a network meta-analysis with the frequentist framework performed by Francesco Brigo and Simona Latanzi, looking at 5 randomized controlled trials with interventions of valproic acid, phenytoin, diazepam, phenobarbital, lacosamide, and levetiracetam. And based on the Aristotelic syllogism, if you compare A with B and B with C, you can indirectly compare C with A. So, and these are the comparisons which have been done, and these are the number of comparisons which have been done, resulting in this busy slide. The important message is here. Whatever is in pinkish is a treatment arm with phenobarbital, and in every treatment comparison, phenobarbital was the only drug which was significantly better than the comparator. That's a very important point. And phenobarbital was not included in any of the trials which we did recently. It was phenytoin versus levetiracetam. So it was superior in with respect to status cessation, and it had the greatest probability of being best in achievement of long-standing or 24-hour seizure control and seizure freedom. And valproic acid and lacosamide had better safety outcomes in this meta-analysis. Brivaracetam, I mentioned already. Well, that might be an option because it enters faster the brain. And as you see from our classification and the conceptual framework, time is brain to a large extent, and levetiracetam takes its time. I mentioned that perampanel is coming as an intravenous solution. There are no data yet. It's undergoing bioequivalent study. But when we use perampanel in the intensive care, we use high doses. 32 milligram is the one we apply standard-wise at the moment. Otherwise, you will not get the adequate serum level. This is the stage treatment approach, and Jakob Christensen is going to talk about the refractory stages. I want to make the point here, don't delay treatment by switching in stage 2. There is no difference between the drugs, and it's highly unlikely that one drug is superior to the other. You just lose time. Pharmacokinetic interactions are important, and failure of phenytoin should lead to consequence of bringing the patient to ICU because it takes half an hour that the phenytoin loading dose is in. There should be a consideration of the risk-benefit ratio of stage 3 treatment in patients with IgE and non-convulsive status, which have a good prognosis, and the ones with an extremely poor prognosis where end-of-life decisions has to be taken. The treatment algorithm, I think Jakob Christensen is going to talk about that. But at the final point, I want to throw up something which is important. We can say, well, it's just the length of the seizure which counts. Or we can say, well, we treat the clinical type, but not the EEG. So in this work led by Simona Latanzi, she used an hierarchical cluster analysis with the Pearson correlation as a similarity measure. So all the clinical data were put into this statistical model, 240 consecutive episodes of status with prominent motor symptoms as diagnosed using our classification, where we simply thought that these were meaningful divisions of groups. And you know the basis of a classification that it identifies biological entities. So these were put into the equation, Etiology was defined symptomatic, remote, progressive, and EEG patterns were given lateralized periodic discharges, generalized periodic discharges, and spontaneous burst suppression. Triphasic or other forms were into the GPDs. According to the treatment response, we classified as responsive, refractory, or super refractory. And then we looked at the etiology, which you see here. And this point is extremely important. On the right, it's status epilepticus dynamics. As I said previously, focal status may evolve into bilateral tonic-clonic status, may evolve into non-convulsive status. And these factors, of course, are important in the analysis of these entities and drawing some conclusions. And what she found, or what we found, is that status epilepticus clusters into 3 different types. There's a 4th one, which is probably only a minor one. You see the clusters based on their similarity and rescale distance, how they appear, are number 1, focal motor evolving into non-convulsive status, LPDs or GPDs on EEG, cryptogenic or unknown etiology, and treatment refractoriness. So that's an important cluster. And you remember the slide which I had at the beginning, that the semiology alone is also predicting. Now we are even better in looking at this cluster. Number 2, spontaneous burst suppression on EEG, super refractoriness, progressive symptomatic etiology, myoclonic convulsive status evolving into comatose, non-convulsive, and convulsive evolving into comatose, non-convulsive. Important categories, poor prognosis. Then we have the 3rd big cluster. It's no LPDs, GPDs, or burst suppression. Good news. Responsive to treatment, yes. Convulsive only, acute symptomatic, and myoclonic only. So that's the good group. And there is one with a remote symptomatic and focal motor only, which stands a little bit alone. And I assume that these are the ones with the structural lesions, tumor, for example, or cavernoma, which per se have a good prognosis. How is it with non-convulsive status epilepticus? This paper is under review. The same principle of thinking, whether the classification really is able to translate into clinical entities with a prognostic implication. So these are the etiological consideration. What comes into this equation, as I said previously, the axis is motor phenomena, prominent or non-prominent, non-convulsive, and level of consciousness, not impaired, mildly impaired, stupor, coma, or deep coma. And this is assessed here with the Glasgow Coma Scale. That's, I think, the only way you can get it out from the patient chart. It was a retrospective review. And again, the EEG, and again, the same statistical method. Here, 3 clusters come out. One with the GCS 3 to 8, which is the lowest groups. They are super refractory, acute symptomatic, and spontaneous burst suppression. Treatment probably has no influence here. My last slide will refer to that. LPDs, refractory status, unknown etiology, and GCS score of 9 to 12, so it's the intermediate group. And the 3rd group is good level of consciousness, 13 to 15, responsive to treatment, progressive symptomatic, remote symptomatic, and no LPDs, GPDs, or burst suppression. So if you see that, I think this graph, which we drafted 12 years ago with Gerhard Bauer from Innsbruck, is very much supported by the finding which we have now. You have a structural brain damage when you have an acute symptomatic or remote symptomatic status epilepticus, and you have an epileptic brain dysfunction. For example, in absent status, there is no structural brain damage, there is just epileptic dysfunction. the level of consciousness, degree of unresponsiveness, low, high, of course, is low. The patient only have minor impairment of consciousness. There is a slight suspension of working memory, but they are definitely not in coma. So it's non-convulsive status proper. Prognosis is good. Here you have an intermediate group with the prognosis. You have epileptic brain dysfunction, but you have a considerable amount of structural brain damage. And here you have the comatose group, and the prognosis is poor, and the structural brain damage prevails, and this makes probably the diagnosis. So if there is something to gain, let's call it mismatch. You can treat the epileptic dysfunction, you can decrease the metabolic demand, and you can hopefully improve the prognosis. But if there is nothing to win because structural brain damage prevails, the patient is in deep coma, and there's only minor contribution of the epileptic brain dysfunction, probably anti-epileptic drugs don't help. And we see that from the Telstar trial in brains after cardiac pulmonary resuscitation. There is not much room to win here. I don't want to recommend that this is a treatment decision, but this is the logical argument for our classification, which we have now, and also the theoretical framework of what I showed you before. The clustering of subtypes of status epilepticus is along the classification, the level of consciousness, the degree of unresponsiveness, and the degree of responsiveness to anti-epileptic drugs. So I conclude, status is a common neurological emergency. Everyone should know about this. The new definition, T1, guides earlier appropriate treatment and provides a framework for treatment escalation, because at T2, we want to prevent brain damage and want to stop seizures. The classification is based on semiology, etiology, and EEG. There's a dichotomy between the convulsive forms and the non-convulsive forms. And these types cluster into clinically prognostically relevant subtypes. So the prominent motor symptoms into 3 big ones and 1 small one, and the non-convulsive into 3 big ones, determining the prognosis, and they are occurring together. A treatment is benzodiazepines in the first stage, anti-epileptic drugs in the second stage. ESET trial showed no difference between those 3, but lacosamide and brivaracetam were not included. Perampanel is going to be developed now, and the trials which are going on is ketamine as an add-on trial early, and ganaxolone as an add-on trial in Europe earlier, in the FDA US design probably later. And of course, I know that you are all interested in status epilepticus. This is the next event. Save the date, a little bit of advertisement for the next London Innsbruck colloquium, and I'm sure that I will see some of you there again. Thank you very much for your attention.
Thank you very much, Dr. Trinka. I have, there are some questions here on the Q&A function, and I'll try to read it up. Michael Keeney, he has written, it is interesting to consider that pre-ictal mechanisms may contribute to the progression of the T1 stage. Any thoughts as to the contribution of the pre-ictal onset neuronal dynamics versus the cascade, which starts the seizure onset in status, which results in progression to T1?
Yeah, very good question. And I think that's one of the very much unsolved things. So if you go back and see very nice books in your bookshelves, it's the Penfield and Jasper. And at that time, the scale was the cortical recording. It was the electrocorticography, which was the standard. Now we have depth recordings, and now we have also intracortical recordings. And these recordings in patients with epilepsy teach us that there are, of course, a lot of changes pre-ictally. So the brief answer to this question is yes, I think they are of great importance, but they are in status epilepticus completely unknown because most of them have acute symptomatic causes. And whatever we know comes from humans with epilepsy, with chronic epilepsy. There might be different changes which are probably more acute in the emergency setting. And it's unclear how long they appear before the ictal phase, before the clinical ictal phase. I think it's a very interesting discussion, and it would of course be ideal to intervene earlier if we know what to do.
Exactly. Yeah. Dr. Benitsky, do you want to add anything? No.
No, I have a question, but I will keep it at the end after you read up the questions from the audience. But if there is some time left, then I would like to ask a question.
All right. Then there is Milton Moran. He has asked about nausea and fires. He is asking whether in what should we base the selection of immunomodulatory treatment? How can we switch from one to another, from, for example, methylprednisolone to immunoglobulin, or cyclophosphamide to plasma exchange? And in the same, there is another question about ketamine in this super refractory status.
Yes, well, I think that's a question where no one can tell you the true answer. To my opinion, it's a little bit like a cooking recipe. Everyone started in, well, let's give corticosteroids in these patients because immunoglobulins are too expensive. In our center, we have membrane plasma separation, which we do very often. So this is one of the first treatments which we give together with immunoglobulins. So it's a matter of cost, resources, availability. There is absolutely no evidence that one treatment stands out from the other. There are definitely series where you can see that, for example, rituximab seems to be better when you use it earlier. There are series where tocilizumab was extremely helpful in cases where you have an interleukin-6 increase before giving tocilizumab. You see, and then there are cases where you bortezomib in patients with NMDR receptor encephalitis. Again, it's completely empirical, and there's no consensus what to give first, what to give second. There is a group discussing this on a regular basis, and Larry Hirsch is always there, and also Nicolas Gaspard. And I think the first step is, of course, to find an expert agreement what to do, and then pool the data and see whether one option seems to be better than the other. At the moment, we cannot really answer your question, and I can only tell you how we do it, starting with immunoglobulins, membrane plasma separation, rituximab, tocilizumab, and then all other treatments come. I'm not very happy with methylprednisolone. It gives you a diabetic metabolism. So if we want to do ketogenic diet, we cannot get it with methylprednisolone to an easy way. We do also neurostimulation. And in this stage, we are with the back to the wall, and we don't have a great success with our treatments at hand. Ketamine, yes, Sami Salama. Ketamine should be used earlier. It's not only in the super refractory. I think it should be used as first treatment. When the patient comes to the ICU, it should be propofol plus ketamine, and I prefer high-dose midazolam plus ketamine, and then followed by propofol. So ketamine makes sense. It doesn't make hypotension. It's cardiorespiratory safe, and I think it's a good drug, which we should move up in the treatment algorithm.
Yes, thank you. I have no more questions here from the, any other questions that Martin or Jakob would like to, or Sandor, yes.
Yeah.
Yes. So congratulations, excellent lecture, Eugen, as usual from you. Now, it's very interesting, your unpublished study on the clustering of non-convulsive status epilepticus. This actually confirms why you made this dichotomy between the comatose and non-comatose, non-convulsive status epilepticus, and actually this is a confirmation also of your hypothesis that you published together with Gerhard Bauer in 2010. Now, the only reason why we call these status epilepticus in these comatose patients is that they have some EEG patterns that resemble the seizures in patients with epilepsy. So the question is this enough to argue that this is actually a status epilepticus, or is this just an EEG pattern in a dying brain that resembles the epileptic pattern? So is that status at all?
Yeah, so easy answer to that question. It's a matter of definition. So when we define it, it's status, we can call it status, but only under the assumption that everyone knows what we are talking about. Confusion only comes when people say it's status and they think it must be correlated with a clinical symptom and this and that. So, but when we define the borders sharp, we will not have a confusion. But as a regular problem in language, in definition, in medical communication, we don't have sharp borders. My personal assumption is that when we use EEG as the only criterion for status epilepticus, we will partly overdiagnose and partly underdiagnose. There might be rhythmic activity on the surface, which is status epilepticus inside. Early reports from Heinz-Gregor Wieser show that. They are hippocampal ictal activity, and on the surface you see blub, 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 nothing special. And on the other hand, if you have a cortical pathology prevailing, like in laminar cortical necrosis after cardiopulmonary resuscitation, you see impressive periodic discharges, and there's invariably death following. So I think when you look at it specifically, it will be difficult to answer. And you know me and I know you. The best way to put forward is to start with a clear definition and then do some research, and then you can modify also your definition and say, well, hypothesis not proven.
Thank you.
Thank you, Dr. Trinka. There was a question from the audience about the dosage of ketamine you prefer.
Yeah, well, that's not very clear which dose is the best dose. I cannot tell you by heart, but we used the ketamine, and this was published by Julia Höfler, sometimes as a bolus, sometimes with a continuous infusion. And I see it now, it's Barbara Schäuble. Barbara Schäuble, I can send you the dose the recommended, or it's not the recommended, it's the one we used. And it's highly erratic and heterogeneous, depending on the situation as the doctors used it. So there is no consensus in what is the right dose. I know that a trial is going on now, ketamine early, and this has a standard dose, which I also cannot give you by heart. But I can send you the, I see now another question, but I can send you the dose. And we use S-ketamine. That was the question by Martin Fabricius. Yeah, we prefer the S-ketamine. Why? Because it's a clear substance and not a racematic mixture. And there is, of course, the pharma, which tells you that it has a better anesthetic property. Whether it has a better anti-epileptic property is unclear. I think there are no studies supporting that.
I have a second question. You nicely showed how the prognosis differs according to the clinical picture. Do you have any flow data to support this subdivision of patients?
Flow data, you mean when one moves to the other?
Yeah.
Well, there are some flow data included in the cluster analysis, which was focal evolving into comatose or bilateral convulsive evolving into comatose. And this also comes from the first draft, which I showed you. It's the electromechanical dissociation, which seems to be the critical point for going into a bad direction. And that's the only data we have. But there are, of course, more dynamic things going on in status epilepticus. It's not only motor to coma, there are also other things going on systemically. We didn't look at the laboratory values when the patient becomes acidotic. On a cross-sectional basis, we know that inflammatory parameters, CRP, are bad signs. So it's open, but the clinical phenomena is motor into non-motor or convulsive into non-convulsive.
And the flow data, are they hypermetabolism into hypometabolism or flow changes?
Okay, so and then I probably had to take your answer in a different way. Yes, we did some flow studies with SPECT and also with PET. And the first I did was several years ago in Innsbruck, and we saw a clear hyperperfusion, hypermetabolic area in the PET in a patient with periodic lateralized discharges at that time. So PLED or now LPDs. And that pointed, well, there is something going on. We treated, and then the metabolism went down again. So these studies we do, but not on a regular basis. What we do now is perfusion measure with MRI. And that is done systematically. We have an MRI protocol looking for structural pathology for diagnostic purposes, but also looking at the flow dynamics using perfusion MRI. That goes quite nicely because you have to have the patient anyway in the MRI to diagnose, and then we take also the perfusion measures there. Studies are going to be published. It's present the first abstract soon.
Thank you. Do we have any?
Dr. Trinka, there is another question, maybe a little bit specific about whether it is possible to give levetiracetam in oral preparation as stage 2 status treatment with an adjusted dose, as Fatul Huda says that in some facilities outside Europe, you cannot have it an IV preparation.
Fatul Huda, that's a bit of a problem because there is a slow absorption of levetiracetam and a slow entry to the brain. So it takes about 20 to 30 minutes to enter the brain, and that's in the case of status 2 slow. So there are studies, of course, benzodiazepines are the fastest. They are really within minutes into the brain when you give it orally. Buccal midazolam or intranasal midazolam is the drug of choice for alternative routes. There is now alprazolam also available in some countries, but I expect that you don't have it in your country. And the thing which was done by an Australian colleague, Beran was his name. He crushed carbamazepine tablets and gave it intrarectally. And that worked because there is a high absorption of carbamazepine by rectal application. It was an epilepsy paper some years ago. So that would be a solution. Oral solution, levetiracetam, slow brain entry, oral valproic acid, fast brain entry, and I would definitely prefer valproic acid or carbamazepine rectally over levetiracetam solution. And the dose for ketamine is 2.55 milligram per kilogram per hour. I looked up in the meantime.
I think, do we have any more questions?
Sidaros, there is an information in the Q&A section about it. Yes, and it's right.
Okay.
I think we should not get ahead of time.
I think I
so-
have another question.
Yeah.
Somebody is talking. Rajib Dutta is asking about perampanel.
Yeah, perampanel. So we use perampanel quite often. We crush the tablets in the meantime, but perampanel is a long half-life, around 70 hours. So you need to use a very high dose. We started with 24 milligrams. Now we use 32 milligrams as a standard dose for the first day. We decrease it a little bit and we do daily serum levels of perampanel in order to get the high dose. So that's, I think, important. There will be an intravenous solution in due time. Bioequivalent studies are going on now in the US. The only problem they had is related to the manufacturing process. So this is why they were a little bit behind schedule, but it will come.
And there is one last question from Dr. Fernandez. He's asking about acute repetitive seizures, I guess about the treatment.
Yeah, good question. We always treat acute repetitive seizures similar to very early phases of status epilepticus. So that's, again, a poorly defined entity, if an entity at all. Most of the time it's in alcohol withdrawal syndromes. So these merge into status epilepticus when there are more than 3 within 1 hour. And in epilepsy syndromes, you can say when the seizure frequency is abnormally increased more than twice than what the usual frequency is. The important thing is when there is a crescendo with a higher frequency and the shorter inter-seizure interval, it starts to treat with benzodiazepines and then go along the schedule. I would also say anti-epileptic drug levels are important to measure in this phase because many of them are related to drug withdrawal. Juan Pablo, satisfied?
I hope so. He cannot. He cannot talk,
Okay.
but he can write if he wants. Yes. I do not see any more questions. I have maybe the very last question, Dr. Trinka. You talked about how much percent of patients are underdosed, like 86%. Of the first treatment. What is, in your experience, what is the timing of EEG? Do you make repetitive EEGs, or you are mostly to the continuous EEG? Especially if you use EEG for treatment response and.
Yeah. So the acute phase, when person comes to our emergency room, which we have, it's a neuro emergency. We have the EEG at hand. During daytime, of course, quickly. During nighttime, we have to call in the nurse. So we give the treatment. When the patient improves, there is no need for an EEG. But if the patient does not improve, you need the EEG in order to do that. So it's usually within the first 1 to 2 hours, even on Sunday night, that we have the EEG based on the clinical decision. In the hospital, of course, it's much quicker. So I think that's one of the things which really improve the diagnosis and which is important to diagnose it early on and not wait when the patient doesn't wake up. Then we get the EEG. You really have to think about in advance.
Okay, thank you. Yeah, I do not have more questions. Thank you very much for the excellent talk and for your participation in our meeting, Dr. Trinka.
Thank you. It was a great pleasure. And enjoy the rest of the meeting. We are starting now a colloquium on rare neurological disorders, which is here in Salzburg, and it's a competition but your session is excellent, and I'm looking forward to see you soon.
Thank you so much, Eugen.
In person.
Thank you very much.
Okay. Bye-bye. Thank you.
I think we should just take a very short pause and be back at 1 or 2 minutes to 2. And now I would like to introduce our next speaker, Chandra Benitsky, professor at Aarhus University and also head of the neurophysiology department at the Danish Epilepsy Center at Philadelphia. Please.
Thank you so much, Martin, for the kind invitation and also for the introduction. Let me see whether I can share my screen. Yes, so I hope that you see by now my PowerPoint presentation. So Eugen has already set the scene for this talk. I'm going to discuss with you the EEG in the diagnosis and management of status epilepticus. This is the outline of my presentation. I'm going to talk about the role of EEG in the diagnosis of status epilepticus. So I will review the EEG criteria for status epilepticus, and I will discuss how accurate these criteria are. Then briefly, I will talk about the role of EEG in management of status epilepticus, more precisely about how we can use EEG to monitor the therapeutic effect and how to monitor the brain function during the withdrawal of the anesthetics. And to try to play with you and put all these criteria into practice, I have prepared some cases with you. So Eugen has already talked about this main dichotomy when we classify status epilepticus. So we have those patients in status epilepticus who have prominent motor symptoms, and then the other category is without prominent motor symptoms or non-convulsive status epilepticus. Well, where do you need the EEG, the third axis, according to the new ILA classification? Well, you can diagnose this without EEG, although I will argue that EEG is a useful tool to monitor the therapeutic effect. But just to set the diagnosis, you do not need EEG here. Yet, to diagnose non-convulsive status epilepticus, you do need the EEG. Without EEG, you cannot put the diagnosis of non-convulsive status epilepticus. Now, very importantly, these two categories are not strictly separated because always the patients have a fluctuating course. So they can start, for example, in status epilepticus with prominent motor symptoms and evolve then into non-convulsive status epilepticus. And as Eugen told you, the clustering showed that this is actually the dangerous thing. And then they can also come back to a convulsive status epilepticus. So don't consider these two categories as strictly separated. They are interconnected. So as you well know, there is a wide variety of ictal EEG patterns, and no surprise, there is also a wide variety of status epilepticus EEG patterns. Back in 2013, at the fourth colloquium on status epilepticus in Salzburg, a panel of experts developed a set of consensus criteria for non-convulsive status epilepticus that later on became known as the Salzburg criteria. Now, this is a very boring table, so I would like to present it rather in a flowchart format. And the first step in this flowchart, the entry, is the clinical suspicion of non-convulsive status epilepticus. So the EEG and the EEG criteria are not just screening methods. You need a clinical suspicion, and this includes the length or the duration of the symptoms. So here already at the step in point, you have that the symptoms must be there for at least 10 minutes. For absent status, it's 15 minutes of loss of consciousness. So the length or duration is already present at the entry, but it's there as a clinical criteria. So if based on these clinical criteria, there is an indication for doing an EEG, then you watch out for the epileptiform discharges. And if the frequency of the epileptiform discharges is beyond 2.5 hertz or cycles per second, then we call this the primary criterion, and this fulfills the first Salzburg criterion, so you can diagnose this as non-convulsive status epilepticus. We thought this was really straightforward, but then we were a little bit surprised when we saw how this was applied into practice in several places. So what we've seen is that people just measured the wavelengths, the duration of the spike wave complex to the reciprocal, and then they calculated the frequency from that. But this is erroneous because although we say that this is a rhythmic discharge, actually this is a quasi-rhythmic discharge. So there is a jitter. So if you just pick one of these cycles, that could be a source of error. And the same is if you just count the number of cycles within 1 second, again, because this is a quasi-rhythmic discharge, so you can be unlucky to count it in a place where the frequency is lower than the average. So the best approach in the clinical practice is to take a 10 seconds epoch to count the number of spike and waves in this quasi-rhythmic 10 epochs period, and that is more reliable. So to avoid any confusion, we defined in detail all these features in a follow-up paper to explain how to implement the Salzburg criteria into praxis. So for example, here you can see this EEG, and this is a 10 seconds epoch, and then there are 31 spike and waves in this 10 seconds period. So this fulfills the primary criterion. Okay, but what if there are epileptiform discharges, but their frequency is under 2.5 hertz? And what if there are no epileptiform discharges, but you can see a continuous quasi-rhythmic delta or theta activity with a frequency higher than 0.5 hertz? Well, in this case, you need at least one secondary criterion. And in this gray box, I will drop you the secondary criteria. And the first one is the so-called typical spatio-temporal evolution. And if you are used to reading EEGs in long-term epilepsy monitoring units, then you're very familiar with this typical EEG pattern of an evolving ictal discharge. So there is a dynamics in space and a dynamics in time. What's the dynamic in time? Well, you follow the discharge, which here you can see starts with a low amplitude, high frequency activity. And then as the time evolves, then this gradually changes. The amplitude gradually increases, and actually the morphology changes also in time. So this is the dynamics in time. And then you have the dynamics in space, which is the propagation of the ictal activity. So here you can see it starts on the left side, and then it also propagates to the contralateral hemisphere. So I'm showing this in our typical Danish way of displaying EEG, where we have color codes like in the political parties, and in Denmark, the socialist, the left wing has a red color. So that's why we use red for the left side. So this is left and this is right. And then of course we defined in detail the evolution. Now the other error that we have quite frequently encountered in different places trying to implement the Salzburg criteria was about the rhythmicity. So this is a schematic representation of what we mean. This is rhythmic or quasi-rhythmic activity. And this is very different, qualitatively different from a polymorphic delta activity. So this is not what we mean when we say this is a rhythmic or quasi-rhythmic activity. So the cycles within this rhythm need to resemble each other at least 50%. I know this is very, very difficult to to measure, but at least 50% resemblance you need between the discharges. Okay, so this was the most important secondary criterion, but there are more. Well, if you can see subtle clinical ictal phenomena time-locked to the EEG discharges, then this also fulfills the Salzburg criteria. What are these subtle semiological signs? Well, these are discrete phenomena like twitches of the eyelids or the face, the jaw, or extremities or the trunk, or head or eye deviation, or peculiar automatisms. They occur when the patient experiences such a degree of encephalopathy that an electromechanical dissociation occurs, so that in spite of the continuous ictal activity in the brain, only subtle motor phenomena are generated. Now, let me show you some examples. So in this first patient, look at the perioral twitches. You can see it here, tiny twitches. Next patient, you can see the thumb, discrete jerks in the thumb. So you could ask, okay, but why isn't this enough? Why do we need EEG? Isn't this enough to diagnose that there are some convulsions? Well, no, because the background etiology can give such phenomena too. For example, if the patient has a lesion in the brainstem, then you can get similar semiology. Or also the drugs that the patients receive in the ICU can generate such phenomena. So we tried to separate these semiological features based on other conditions and based on status epilepticus, only based on the semiology features, and we could not. So we looked at what the patient does, myoclonus or a tonic muscle activity or automatisms or eye deviation, in which body part, or what's the temporal dynamics on it. But if we look only at these semiology features, we could not distinguish between the non-convulsive and the coma cases. So you really need the EEG also in these cases with a subtle semiology. Okay, the next secondary criterion is when you look at the effect of IV anti-epileptic drugs given during the recording. So again, this has been misinterpreted. So I was surprised when I heard at lectures how some other centers try to implement this, saying that, okay, we treated the patient for 3 days and then the patient recovered. So this meant that this criterion was fulfilled. No, no, no. This is looking at the modulation of the EEG and also of the clinical background during the recording itself. So if you give intravenous anti-epileptic drugs and you can see a clear-cut EEG and clinical improvement, then you can diagnose again the non-convulsive status epilepticus. So let me show you some examples. So here you can see the spike, polyspike and waves. They are coming focally and continuously, yet their frequency is not sufficient to fulfill the primary criterion. So we tried also intravenous anti-epileptic drugs. And what you can see is that first, the abnormalities, the spike and waves disappear. And second, most importantly, there is an improvement also in the background activity. And then if the patient also improves clinically, then you can diagnose it as a definite non-convulsive status epilepticus. This is often the case in a patient who has a predefined or pre-diagnosed epilepsy, taking medicine, but then forgets taking the anti-epileptic drugs and then goes into status epilepticus. It's rarely the case in the ICU. So what happens there is that you can see that the EEG improves, but you rarely can see a clinical improvement. So in this case, you say that this is a possible non-convulsive status epilepticus if only the EEG improves, but you cannot really assess the clinical improvement. And then there is one more important aspect, this phenomenon of fluctuation. So you remember that the evolution is a gradual change, stepwise change in the same direction. So for example, the frequency increases by 0.5 hertz, and then after at least 3 cycles, it even increases more with 0.5 hertz in the same direction. But if you have this other phenomenon, this ping pong back and forth between 2 frequencies, then you call it a fluctuation. So this is not sufficient to diagnose an evolution or to say this is an evolution, but it's also a potentially dangerous phenomenon which can be non-convulsive status epilepticus. So if fluctuation is present and no other secondary criteria are fulfilled, then you call this again a possible non-convulsive status epilepticus. Now, how long do you need to see these criteria fulfilled? And according to the Salzburg consensus criteria, this is 10 seconds. And always people get shocked when I'm saying this, because they jump up and say, but how can you call this status epilepticus if it's there only for 10 seconds? But that's not what I'm saying. What I'm saying is that the whole EEG is abnormal, but the climax where all these abnormalities reach such a degree that they fulfill the criteria, that needs to be 10 seconds. But you already have the duration defined by the ILAE classification and definition of the status epilepticus at the entry point. So remember, just to enter this flowchart, you need at least 10 minutes, or for the absence status, at least 15 minutes of symptoms there. So the duration of 10 and 15 minutes is here at the entry into this flowchart. Now, there is another important aspect that I have to emphasize here, and this is the special case of especially children with developmental and epileptic encephalopathy. Children with West syndrome, Lennox-Gastaut syndrome, status epilepticus during sleep, electric status epilepticus during sleep. Well, these children typically have a horrible, very abnormal EEG, also in the interictal period because of this epileptic encephalopathy. So if you would just record an interictal EEG, they could fulfill several of these criteria. So to avoid that these poor children are overtreated, for this case of developmental epileptic encephalopathy, you need some additional criteria to be present in order to diagnose non-convulsive status epilepticus. So you need either an increase in prominence or frequency of the features mentioned above when compared to the baseline, and observable change in clinical state. Now, fortunately, we always have previous EEGs in these children. Often you can see 10, 20 previous EEGs in your database. So often you can compare the current EEG with the previous EEG. And then you always can ask the caregivers whether there was also a clinical worsening during this period. But if you cannot do this, then there is another way around, and that is making this branch of the Salzburg criteria compulsory. So there must be an improvement both electrographically and clinically on IV anti-epileptic drugs. So how accurate is this? And does this work in all the different types of non-convulsive status epilepticus patients? Well, remember that previous criteria have been suggested too, but none of them have ever been validated clinically. So we conducted a multi-center study in Aarhus, Diana-Lund, and Salzburg, and we found that the inter-rater agreement for application of the Salzburg criteria is very high, beyond 0.8. And giving a very high sensitivity, almost 100%, we only missed one patient who proved to have non-convulsive status epilepticus, so a sensitivity of 97.7%, an acceptable specificity around 90%. This gives you an overall accuracy of 92.5%. And then we did subgroup analysis. We looked at the patients with coma and non-coma, patients who are post-hypoxic, and the other patients with pre-existing epilepsy and without pre-existing epilepsy, patients with and without epileptic encephalopathy, and patients younger and older than 10 years. and there was no difference. The Salzburg criteria worked in all these subgroups. Why? Because there is no single criterion, but rather many branches of different criteria. So these many branches of the Salzburg criteria can accommodate the complexity of the numerous status epilepticus patterns. So we concluded that the Salzburg criteria for non-convulsive status epilepticus have a high diagnostic accuracy, have an excellent inter-rater agreement, and they are suitable for implementation in clinical practice. Now, there is an issue, a challenge in critically ill patients, especially if you have the luxury of doing many continuous EEG recordings in the intensive care units. Then it's very difficult to apply this entry criterion, because if the patient has been lying there in the ICU and sedated, you cannot really tell that there are clinical symptoms there for 10 minutes or 15 minutes. So in this case of critically ill patients, then you need a set of criteria that is EEG only. And then you will hear the new ACNS terminology and ACNS guideline from Larry Hirsch after my talk. I would just like to give you the heads up and to show you how these Salzburg criteria are now converted into the criteria for the patients who are critically ill. So for these two criteria, so the frequency beyond 2.5 hertz of the epileptiform discharges and the typical evolution, you need at least 10 continuous minutes of this EEG phenomena. Or if they are fragmented, then totally you need 20% of 1 hour. Why? Because we know that this seizure burden is as detrimental for the outcome as the continuous 10 minutes. So this is how they are converted now to EEG only criteria for those patients where you cannot measure the duration or the length based on the clinical criteria. Now these two, the subtle clinical phenomena, if they are time locked to the EEG, and if there is an improvement, both electrographic and clinical, on the IV anti-epileptic drugs. Now in the new ACNS terminology, they are considered electroclinical seizures or status epilepticus. Because why? Because here you have a clinical improvement too, and here the EEG confirms that these subtle things are actually clinical. So these are renamed as electroclinical seizures or status epilepticus. And then the phenomenon of fluctuation is now for the critically ill patients considered part of the ictal interictal continuum. But Larry Hirsch will talk about this in detail now. I just wanted to show you how the Salzburg criteria were translated now into the ACNS criteria for seizures and status epilepticus. Now let's look at how we can use the EEG in monitoring the therapeutic effect, that is the depth of the anesthesia, the therapeutic coma. So EEG is excellent because you can step by step follow the depth of the effect. So as you know, the first thing you can notice is an increase in the beta power, then an increase in the delta power. Then comes a suppression with increasing duration and burst with decreasing duration. And then you end up in an isoelectric EEG if you choose to go to that depth. And then when you withdraw, everything goes into the opposite direction. So first you can notice some burst with increasing duration, suppression with decreasing duration, then beta, then delta, and again beta. So it's everything in the opposite direction. So everyone would agree that the target here is seizure suppression, but there is no consensus on how deep you should go with the therapeutic coma. Should you aim for a burst suppression or should you aim for a total suppression with isoelectric EEG? Most centers, when it comes to burst suppression, most centers aim for this combination of bursts that are up to 5-second duration and the suppression that is around 10 seconds plus minus 2 seconds. So between 8 and 2 seconds suppression. So here you can see a very nice burst suppression pattern induced by the anesthetic. And then here, this went to the total suppression. And then you can use EEG also to monitor the brain function during the withdrawal of the anesthetics after you think that the status epilepticus is over. And then you can use the EEG to ask the question, do these seizures or does the status epilepticus return? Is there an emergence of the EEG patterns indicating increased seizure risk? But here I must mention a caveat, namely the paradoxical effect of drug withdrawal, because the anesthetic wean actually causes a hyperexcitability. So there have been described cases of successful wean despite emergence of the ictal-interictal EEG patterns during the weaning. So please keep this in mind, not to be too jumpy based on the EEG patterns encountered during the weaning. Okay, now let's say some cases to apply all these criteria into clinical practice. So case one is a 72-year-old male, had a thalamic hemorrhage and right hemipulse. And then 3 days after the admission, the patient developed altered consciousness, Glasgow-Combe scale of 10. They did a CT, which did not show any new lesion, no hemorrhage, and nothing else could explain the change in the status of the patient. And here you can see the EEG. Again, red is on the left side. So here you can see these nice lateralized periodic discharges around 1 Hertz. And then all of a sudden, where I marked it here, it changes to another frequency. It goes to 2 Hertz frequency. And then it comes back to 1 Hertz frequency and then again to 2 Hertz frequency. So how would you classify this according to the Salzburg criteria? Well, you have this, you have a fluctuation, and this qualifies as a possible non-convulsive status epilepticus. According to the new ACNS guideline, this would be an ictal-interictal continuum. Okay, let's see the next case. This is a 78-year-old female patient. 2 years prior to the admission, the patient had an ischemic stroke, right middle cerebral artery, and then in consequence, the patient has palsy on the left side. So 1 day prior to the admission, the patient became agitated, developed a loss of consciousness, and then they observed periods of 30 to 90 seconds with discrete jerks in the paretic in the left upper arm. The CT showed no new lesion. And then we did an EEG. And then please observe these delta waves in C4 in the right central area. And then in green at the bottom, we have the surface electromyography. So you can see that the jerks in the left arm are time locked to these delta waves in C4. This is just artifacts. So on the left side, you can see artifacts, but this is actually the time locked EEG phenomenon. So let me show you the video. So look at the jerks in the left arm. So how is this classified according to the Salzburg criteria? Well, yeah, subtle clinical ictal phenomena time locked to the EEG abnormality. So this qualifies as a definite non-convulsive status epilepticus. According to the new ACNS criteria, this would be an electroclinical seizure or status epilepticus because the EEG confirmed the epileptic nature of this phenomenon. Okay, third case is a 67-year-old male patient who had a cardiac arrest, and then 3 days after the return of the spontaneous circulation, we recorded this EEG. You can see it's continuous, but it's low amplitude, it's a diffuse delta activity. And then during the nociceptive stimulation, you can see that the patient is actually reactive. So again, nothing that would qualify as any of the criteria of these Salzburg criteria for non-convulsive status epilepticus. So this patient does not fulfill our non-convulsive status epilepticus criteria. The next case is a 71-year-old male patient, again, cardiac arrest, and then 3 days after the return of the spontaneous circulation with Glasgow Coma scale of 8, the personnel observed periods with discrete jerks. Then we recorded this EEG, and this went on for hours. So you can see these discharges, bilateral, symmetrical, and synchronous, and the frequency is constantly 3 Hertz. So you take 10 seconds, then you count 30 discharges. So this fulfills the primary criterion. So you have these epileptiform discharges with a frequency higher than 2.5 Hertz. So you can diagnose this as a definite non-convulsive status epilepticus. And the fifth case is an 82-year-old female, again, cardiac arrest. 3 days after the return of spontaneous circulation, the personnel observed myoclonic jerks. The patient was put on propofol and the jerks stopped. And this was the EEG while on propofol. And then propofol was withdrawn, and you can see the same discharges, a little bit more fulminant. And then let me show you what happens during these discharges. Myoclonus, and then again a discrete myoclonus. So again, these are subtle clinical ictal phenomena time locked to the EEG pattern. So this again is a definite non-convulsive status epilepticus. So to sum this up, please remember this flow chart, and if you rarely apply it, then it can be a good idea saving it or posting it on the wall so that you can use it when you need it. So this is the Salzburg criteria. And then remember that this has been translated later on to apply for the critically ill patients. And in red, you can see how this has been translated in the new ACNS guideline that Larry Hirsch will talk about. So again, these two corresponds to the 10 minutes of continuous EEG abnormalities with frequency about above 2.5 Hertz or a typical spatiotemporal evolution, either in one piece or fragmented, but it should be at least 20% of 1 hour. And then these are the electroclinical seizures. This is a possible electroclinical seizure. And then this is now in the ACNS criteria, the ictal interictal continuum. And with this aerial photo of the Aarhus University Hospital, I would like to close my lecture and thank you for your attention. I'm looking forward to answering questions.
Thank you very much, Shandor. Yeah, there are many questions. Thank you for the excellent talk. And I will start with some question from Dr. Fabricius. He has two, so I'll try to start with the one. The first one, he's asking whether this 2.5 Hertz limit is for polyspike spike waves, but not for other types of epileptiform discharges?
Yes. So the question is whether Martin is asking about the Salzburg criteria. So now, when we formulated the Salzburg criteria, then we defined this for epileptiform discharges of spike waves or polyspike waves. Now, in the ACNS criteria, this also applies for PDs, which are spiky, sharp or spiky PDs too. And the second question?
And the second question is about the case one. Dr. Fabricius asked whether the patient, why do we apply the ACNS criteria because the patient was not critically ill and not instead saying that he had a possible status?
So the case one, I think the case one was the one with the thalamic infarction, right? So let me see which was the case one. Yes. So in case one, this well, the patient had a GCS of 10, and then yeah, there was some altered consciousness indeed. So again, if you go for the Salzburg criteria, not for the ACNS criteria, but if you go for the Salzburg criteria, you still have a fluctuation. Yes. And then that would qualify as a possible non-convulsive.
Darren Ginpei that asks about should we choose an IV benzodiazepine or a non-sedative IV drug to see the clinical improvement?
Yes. So I must admit this is a weakness of the criteria. So you know, there is always a balance between feasibility and precision. We never came to define what we precisely mean by IV anti-epileptic drugs. Most often it's a benzodiazepine that you use, but in many patients who have been on anesthetic treatments and on the ICU, this will not make a big difference. So in many centers, then also phase 2 and anti-epileptic treatment is also applied. So in the original definition, we mainly thought of the benzodiazepines, but we never specified this. But also, if you can go for valproate, for example. But the essence is that regardless of what you use, you must see this modulatory effect within the recording. So it's not that you treat it with some anti-epileptic drugs on several days and then post hoc you conclude that this had been a non-convulsive status because the patient recovered.
Yes, there's a question from Michael Keeney. Dr. Keeney asks whether in your opinion, do you know how widely utilized is the Salzburg criteria? It's not known would be a useful survey, he asks.
Well, that's an interesting question. I don't have any answer for that, but I can tell you that before the Corona lockdown us, and I was traveling, so I often saw the flowchart of the Salzburg criteria on the walls of neurophysiology services. And it's very well cited, so I assume that it's quite broadly used, but I cannot tell you how many centers or hospitals implemented that in their local regulations.
Yes, and Dr. Kinney, he has another question, a follow-up question. How well do the specific subtypes of the criteria correspond to the prognosis in your experience?
Yes, this is something that we would like to look at it. I don't have yet results. What we did in our paper, multi-center validation study, we looked at which criteria were fulfilled. And then what we've seen that often these criteria were combined. And then no surprise, those types of criteria that are mainly in those categories that Eugen talked about during the clustering, so that you typically see this fluctuation, for example, in patients with comatose non-convulsive status epilepticus, those were related to a bad prognosis. But it's not because of the EG criterion, but it's because that it's confounding with exactly that category or cluster that has a poor prognosis.
Yes, Dr. Fernandez asked whether about the clinic this criteria of improvement, the clinical improvement. How long should I wait after IV AED?
Yeah, so again, there is some flexibility in how this is defined, and also not just the time, but also the depths. But the improvement should be within minutes. Yes,
Dr. Sidaros, she has, I think, two questions. One is about the lower frequency of in the Salzburg criteria. Is there a lower frequency, 0.5 hertz or lower?
Yeah. Yeah, so not in the Salzburg criteria, but in the ACNS criteria, now these are considered part of the ictal-interictal continuum. So if you have these discharges under 2.5 Hertz, but beyond 1 Hertz, then they qualify not as a seizure, but as a part of the ictal-interictal continuum, which is an evolving concept. But logically, so if you use your common sense, all these patients have a fluctuating course, so it also depends on your sampling in time. But also you should try to avoid a very strict cutoff values. Now we had to choose one cutoff value because otherwise we could not have done any systematic study on it. I must tell you honestly, when we discussed it, we said, okay, 3 Hertz was what many groups suggested before, but in the experience, we've seen many patients in status who are lower. Yes, but if we would have gone down to 2 Hertz, then there would be too many false positives. So we compromised at the 2.5 Hertz. But again, the data with the flow studies that Eugen showed you later on proved that going for the 2.5 Hertz was a really reasonable choice. But again, so the short answer is the under
Annette
2.5
follows up with
a
question about the case with the cardiac arrest. She asked whether this burst suppression and myoclonia time log burst, like in your last case, should we regard this as status at all?
Yeah. Yeah, it's status myoclonicus, and in a post-hypoxic patient, this usually is associated with a poor prognosis, unless the somatosensory evoked potentials and the brainstem reflexes are preserved, then the prognosis is poor. So this is a myoclonic status myoclonicus indeed.
Yes, I think Victoria Fernandez is also asking about the same regarding the case with cardiac arrest and myoclonias. Would it be a severe hypoxia encephalopathy with myoclonia, like status instead of non-convulsive? But I think you responded to that, yes. Or it's just a matter of terminology?
Well, you know, as Eugen said, it's a matter of definition, and then when we look at the phenomenology. So you've seen the same EEG discharges without absolutely no myoclonus when the patient was on propofol, and then as the propofol withdrew, then some discrete myoclonic jerks appeared, and later on some more overt myoclonic jerks appeared. In the first phase with discrete myoclonic jerks, this would be a subtle myoclonus, then it would still qualify according to the ILA classification as non-convulsive status in coma. And then later on with more overt myoclonic jerks, then it would be with prominent motor symptoms, myoclonic status in a coma patient, so to the left part of the classification. Yeah. So again, what I mentioned is that there is a fluctuating course. So these taxonomic entities are not born and in some boxes. There is a dynamic change between them.
There is one question about from Dr. Moran. He's asking whether how reliable it is to guide the diagnosis and management of a patient with suspected autoimmune encephalitis based on the EEG when there is extreme delta brush. Yeah, so a recent study suggested that actually the diffuse delta is much more sensitive in the cases of this NMDA receptor antibody encephalitis. But of course, if you see the classical typical delta brushes, then the specificity is high. I must admit, when we and this will tell you a little bit also on how often you see that pattern. So when we published the new ACNS criteria, then we collected typical examples. Now there was a big group who authored the ACNS criteria. We were not able to find one typical example. So this tells you that, yeah, this is very specific if you catch it, but it's not really a frequent phenomenon. Yes. Dr. Bilgor asks whether how much clinical improvement after benzodiazepine is needed to have a clear clinical positive response?
Yeah, again, this is to some degree subjective, although in the follow-up paper we try to define it, but it also always is relying on your clinical judgment. So if the patient becomes more oriented or opens the eyes, have some more response. So if you consider that during this relatively short period of time after giving the IV anti-epileptic drugs, there is a significant improvement as your clinical judgment, then that is sufficient to fulfill the criteria. It's very difficult. We attempt it, but it's in the practice is very difficult to standardize this because there is a very broad spectrum of the conditions. So it's very difficult to standardize.
Yes, thank you. There is another question about, do you use photostimulation in patients in coma?
Well, we use nociceptive stimulation. So there has been guidelines suggest or a standardized protocol suggested for this. So that is what we do. So acoustic, passive eye opening, and a series of nociceptive stimulations.
Yes, there is another question from Karina, Brazil. She asked whether the burst suppression with epileptiform discharges in each burst should be overloaded to isoelectric pattern besides optimizing AEDs.
Again, there is no consensus and there is no class 1 evidence on that. So the practice would differ very much from center to center. Indeed, some centers would go to the extreme and load until achieving an isoelectric EEG.
Yes, I have no more questions in the panel here. Maybe Martin want to. What? Oh, I thought.
So I would like to welcome
there is a
Larry
question here from.
Yes.
There is a question here from the room. We have been talking, Chandra, about the background activity as one of the elements of the improvement of the EEG. Your thoughts about that?
Yes. So if I may start with a very personal and subjective thing, you know when you write some criteria, then you it's very difficult to gather your thoughts. And twice it happened to me that people asked something and I said it's in the criteria, it's written, and then when we looked at the paper, it wasn't there. And the first when it happened to me was when we published in Epilepsia First the Salzburg criteria. I was sure that we put the 10 seconds there, and then people were showing me, no, it's not there, and they were right. And then we said, oh gosh, how could we not put that into? And the second thing is exactly with the improvement of the background activity. So I was convinced that that everyone, when assesses the improvement of the EEG based on giving intravenous anti-epileptic drugs, there are two things. First, the abnormalities epileptiform discharges need to disappear, or at least their frequency must go down significantly. And there must be an improvement in the EEG background activity. We always applied these criteria like this, but we never explicitly put that into the paper. So yes, next time we will need to specify this in more detail. So when we apply this criteria, we always ask also for an improvement in the background activity so that the EEG qualifies as an improved EEG. Larry, may I ask, do you do that? Do you look at the improvement of the background improvement when you assess whether the EEG?
Yes, yeah, absolutely. But to be a successful trial based just on that is difficult unless it's really clear improvement. But yeah, when they clinically improve, you'll virtually always see an improvement in the background. In some cases, though, it's hard to know what the background is if they had enough.
Right. So that's why we call it a possible, right?
Right.
There is another question which I think connects to the last discussion is about the patient in ICU where you cannot assess clinical improvement. How do you know that the changes on EEG aren't just a reaction to the treatment?
Well, you don't. So that's why you call it a possible. Yeah, indeed.
Yes.
Thank you, Sander.
Thank you.
Very informative. I think we will take a break and I'll be back and introduce the next speaker a minute to 3 o'clock. I think we are back after the short break. To follow up on the last talk about EEG, we have invited Lauren Serge to talk about how to use standardized critical care EEG terminology. Professor Hertz is professor at Yale School of Medicine. He heads the Division of Epilepsy and EEG and is also co-director of the Yale Comprehensive Epilepsy Center. Please, Larry.
Great, thank you very much. Appreciate the invitation, and luckily Shandor covered a lot of the more difficult part of my talk, so that will be helpful. All right, let me share my screen here. All right. Hopefully everybody can see okay, but let me know if not. So I will cover the American Clinical Neurophysiology Society's new version, just came out this year, on the standardized critical care EEG terminology. These are my disclosures. These are the relevant ones, including having borrowed or stolen slides from many of my colleagues. These are some unrelated ones. Okay, so this started a long time ago. It's really close to 20 years ago, where we first got together to create some standardized terminology for these complicated patterns you see in critically ill patients. And initially, this was a little subcommittee of a total of 12 people, and it was all research terminology. And the word research was in it. So we proposed some standard terms, and you can see who was here, and it was all just from North America. But again, that was just for research at that point. By 2012, we published the next version, and this one, the word research was taken out, and this was a formal guideline from ACNS on how to describe critical care EEG patterns in clinical practice. And you can see it was a much larger group, but again, mostly from North America. In fact, the only one who wasn't was Dr. Gaspard from Belgium, but he actually spent several years at Yale. So very North American centric. Then coming to the future, actually coming to the present, the latest version, and you'll recognize a lot of the names. This one had 30 authors from 8 countries and 4 continents, and took many years to get together and many long meetings, including late at night and on weird hours. And you can imagine trying to get everyone to agree on these terms and definitions is not easy. So this is the 2021 version. Okay, so the primary objectives of all this is to allow proper communication, not only clinically, but for scientific investigation, with the ultimate goal of figuring out which patterns require treatment, which ones are harmful for the brain, and exactly how to manage these patients. It's intended to be used in all ages except for neonates. There is a separate neonatal terminology. It's probably not ideal for infants, but certainly over age 2 or so, it applies just fine. All right, so let's get to the meat of the terminology. So it's quite simple. There's 2 main terms, main term 1 and 2. Main term 1 says where the pattern is. Main term 2 tells you what the pattern is. So these are the 4 terms for describing the location. So there's generalized, lateralized, and that includes anything that's lateralized, focal, regional, all those are lumped under lateralized. There's bilateral independent and multifocal. And in the new version, there is unilateral independent. So that's two patterns from the same hemisphere, but that are doing their own thing, not time locked and not dependent on each other. And then main term 2 has not changed at all. There's periodic discharges, rhythmic delta, and spike wave. So those are as far as main term number 2, these are their definitions. So for all of them, it has to be repeating waveforms or discharges with relatively uniform morphology at nearly regular intervals. And the difference between periodic and rhythmic is in periodic, you have an interdischarge interval. And nearly regular is defined as the cycle length has to vary by less than 50% in the majority of pairs. And I did think Shandor made a very important point, not to call everything that's just high amplitude delta, they're not to call all that rhythmic. And that's probably the biggest mistake I see is calling rhythmic delta activity when it's actually polymorphic delta. So that is definitely an important point. So here's an example, periodic. There's a discharge of any kind. It doesn't have to be epileptiform. It can just be a blunt delta wave. Then there's a discharge. And I'm sorry, that's the discharge. Then there's an interdischarge interval, another discharge. And there have to be at least 6 of these. You have to have 6 cycles in a row for it to qualify as being present. And here's rhythmic. So it can be the exact same discharge, but without a break between them that makes it rhythmic. And patients will sometimes vary. There'll be an interdischarge interval, then it'll get a little faster and it'll be gone. And so it'll switch to a rhythmic pattern. So many people will have both periodic patterns and rhythmic patterns. And this is spike wave, has to be a very regular alternating pattern, spike, then wave, spike, then wave. And there has to be no interdischarge interval. So if it's a spike and wave and then a break and then another spike and wave, that's periodic discharges. So here's some examples of rhythmic delta. Can look like this. These first 3 are all examples of rhythmic delta, just with different morphologies, but they're pretty regular. And this last one is an example of something that is not rhythmic at all. So that's polymorphic delta and does not qualify as RDA. All right, so that's basically the main gist of the describing the rhythmic and periodic patterns, and we lumped them all together and call them RPPs, rhythmic and periodic patterns. Then there's a whole bunch of modifiers. It's really just standardizing these. There's not a lot of rocket science or interesting material in here, but it's just to use standard terms. So I'll show you a bunch of examples. I think all these EEGs are going to have a similar montage. So it'll be left parasagittal, then right parasagittal, then left temporal, then right temporal, and midline near the bottom. So here's an example of lateralized periodic discharges. Here's another example where they're sharper, but farther apart. Here's an example where you can see they're not, frankly, epileptiform because they're too broad for that. But this is an example of lateralized periodic discharges as well. And there are modifiers for how sharp it is and their frequency, of course. And here's an example also of lateralized periodic discharge, but this time with a spike and wave morphology. But because there's a clear break between each one, it's still periodic discharges. Okay, so this is not an SW pattern, it's a PD pattern. Here's an example of bilateral independent periodic discharges. You can see the ones here on the right are going on their own, completely separate from what's going on the left. Okay, here's an example of a very generalized pattern. So they're all synchronous generalized discharges with a break between them. Here's another example of generalized periodic discharges, this time with more of a background between them. And here's another pattern where this is a compressed EEG, so every 5 seconds you see this burst of kind of polyspike activity. Now this is just to make sure you're paying attention, because whenever you see something every 5 seconds in a comatose patient who's intubated, you should really look very carefully, because usually it's respiratory artifact, which is what this is. This is actually fluid in the tubing of the ventilator, and you remove the fluid and this artifact goes away. And here's a GSW pattern, a generalized spike wave. So you can see there's a spike, then a wave, a spike, then a wave, a spike, then a wave, and at least 6 in a row. This is fairly unusual pattern in the critically ill. This is an example of periodic pattern here, and then a separate one at the midline. So when midline and another one happens, we call those, they're considered part of the unilateral independent. Obviously, midline doesn't have a side, but rather than making a whole new terminology for that, or counting it as a third location, we just lump that into the unilateral independent category. And then here's a nice example of periodic discharges in 3 different locations. So you have this blunt one in the left parasagittal, you have this nice focal sharp one at F4, and then a separate one here at P4. You have to take my word for it that there's at least 3 more of them. This was from Dr. Caboclo, sent this to us. So a good example of multifocal periodic discharges. All right, so this is an example of a lateralized rhythmic delta activity. And these little stars are showing the sharp component in there as well, which would make it a plus S, which I'll get to in a bit. So this is lateralized rhythmic delta activity with a plus S modifier. Okay, so this is one. So this is in an average reference montage, and this time the whole right hemisphere is on the bottom. And you'll see there is a rhythmic delta pattern. Maybe it's not the greatest example. There's a hint of it breaking up, but from here in the right frontal, and then another one in the temporal lobe, and they're going at different frequencies. This one's slower and independent. So this is unilateral independent rhythmic delta activity. So RDA in 2 different locations in the same hemisphere. All right, so some of the other modifiers, again, is just to standardize terminology. If you say there's frequent lateralized periodic discharges, you mean that they occupy 10 to 49% of the record. If you say they're abundant, it's more than 50%, etc. So it's just to be standardized. Similarly, for the duration of each pattern itself, or each instance of the pattern, anything less than 10 seconds is very brief. Less than a minute is brief. If it's 1 to 10 minutes, it's intermediate duration. We couldn't find a good English word for that. And if it's 10 minutes to an hour, it's long. The only change from the prior version was this used to be 5 minutes, but we changed it to 10 minutes to match the ILAE definition of status when it's not convulsive. Okay, so this is the plus modifier. So this is any additional feature that makes the pattern more ictal appearing than the same pattern when there's no plus. So you can either have superimposed fast activity, superimposed rhythmic activity, or superimposed sharp waves. And the other way to be a plus S is if the pattern itself is sharply contoured, and that only applies to rhythmic delta. So here's an example of where each discharge has a little burst of fast activity with it. So this would be an LPD plus F. Here's an example where you would really have a tough time deciding whether to call it periodic discharges or rhythmic delta. And it's not spike wave because you see the spike is moving around and not in a stereotype relationship to the wave. So it's not a very regular spiked in wave, spiked in wave. So this actually is fairly common, where it qualifies both as periodic discharges and as rhythmic delta, and they're both fairly equal. And just we decided when that happens that the periodic discharges trumps the rhythmic delta, so you should call this periodic discharges plus R because of the rhythmic component. Okay, so this one is more on the it's clearly much more on the right hemisphere than the left, which makes it lateralized. So this is LPDs plus R. I'll just make one other comment about that. So if you see it bilaterally, that doesn't make it generalized. If it's clearly more prominent on one side, then that's called a lateralized pattern. And there's a separate modifier. You can say whether it's purely unilateral or if it's bilateral asymmetric, but that still falls under lateralized periodic discharges. Okay, so then you heard about evolution and fluctuation already, so I'm not going to talk about this. They apply to frequency, location, and morphology, not amplitude alone. So just evolving or amplitude does not qualify. You have to have one of these other things. So this is, as far as evolution of frequency, for example, you have to have at least 2 unequivocal sequential changes in frequency, each one by at least 0.5 hertz. It's actually, evolution was never really defined prior to the last version of the ACNS criteria, and it's not that easy to define. It's almost impossible to define evolution in morphology. And here's just some examples of evolution of location that's straight out of the nomenclature publication. So here's one example where it spreads within one hemisphere, and another one where it spreads first in one hemisphere and then to the other side. And it has to be at least 2 instances of changing location and using standard 1020 electrode locations. And fluctuation, I think you heard this definition. It's at least 3 changes less than a minute apart in one of those 3 criteria again. Okay, but not qualifying as evolving. So here's an example where it goes from about 4 hertz down to 2 hertz and back up to 4, back down, and 2 different kinds of morphologies doing the same thing. So these would be fluctuating patterns. So here's an example. I just want to make sure people know. So this one you don't call periodic discharges or anything like that. This is way over 2.5 per second. This is just electrographic seizure, and depending on the duration might be electrographic status epilepticus. All right, another modifier is the effect of stimulation on a pattern. So previously there was a stimulus-induced prefix, this SI. In the new version, there's also a stimulus-terminated prefix. I can tell you the stimulus-induced is much, much more common than the stimulus-terminated. And so for stimulus-induced, this means if you take a person in their resting or most asleep, least awake state, I mean, it's often coma or deeper stupor, and then you stimulate them with any alerting stimulus, you will see one of these rhythmic or periodic patterns come out or frank seizures. And as long as you know that you can bring that out with alerting, that qualifies as stimulus-induced. They may also have it spontaneously at other times because everybody has internal stimuli or pain or other kinds of stimuli. So that's fine as long as you can show that it can be brought out by stimulation. That makes it a stimulus-induced pattern. Also, stimulus exacerbated counts in this category too. If it's clearly much more prominent or faster or something like that, then that falls under SI as well. And then ST is the opposite. You can reproducibly stop a pattern by alerting the patient. And then the correlate, if they're not related to stimulation, then it's just spontaneous. And many times you'll have a short record where they haven't been stimulated at all and it's unclear. So here's an example about if you lump all these patterns together, they're known as SERPIDs, stimulus-induced rhythmic, periodic, or ictal discharges. But it's much more important to describe the pattern and just put the SI prefix because they're extremely different. Stimulus-induced generalized rhythmic delta is very different than stimulus-induced electrographic seizure. So to me, to lump them all, even though I'm the one who came up with that name many years ago, to lump them all really doesn't make much sense. You should deal with the individual pattern that's brought out. So here's an example of sternal rub followed by generalized periodic discharges. So this would be SI-GPD, stimulus-induced generalized periodic discharges. Here's an example of an electrographic seizure induced by stimulation. So you hear the staff enters the room and stimulates the patient. And you'll see maximal here in right parasagittal region, the start of a seizure. And the next page, it's continuing and turns into this low voltage fast activity. So it's a focal, evolving, definite electrographic seizure that's reproducibly brought out by alerting stimuli. So this would be a stimulus-induced seizure. And now the vast majority of time, those are purely electrographic phenomenon, but a small percent of the time you'll actually see clinical correlate, and this is an example of that. Let's see if I can play it. So you will see her eyes are closed here and her hand is not moving. But then the tech will come in, do our intranasal tickling. This is a tickle, not a painful stimulus. And it's not a COVID test. It's just very superficial. And watch her eyes. She will open her eyes and then you'll start to see twitching of this hand. You see hand twitching, and now the eyes are open and looking up to the right. So this is the EEG during that. The stimulation happened back here. At first, it just looks like a reactive EEG. You think, oh, it's good, nice and reactive, better background. But then it continues to evolve. The twitching starts here, and eventually it's clearly an evolving electrographic and clinical seizure. And this could be done over and over. So this is a stimulus-induced clinical seizure. All right, so while we started doing this terminology, people asked us to standardize some other things that were not well defined. So we got into the interictal discharge, just standardized terms as well. So for someone who has occasional spikes, that means they're somewhere between once a minute and once an hour. If they're frequent, they're between once a minute and once a page, or once every 10 seconds. And abundant means they're every 10 seconds on average. Okay. And then we tried to standardize the background as well. There nothing too interesting here. The only change was we added beta as a separate background. It used to just say alpha or faster. Now there's a separate beta category. And these things are all included in the nomenclature. One of the new ones is this term called CAPE, cyclic alternating pattern of encephalopathy. And that's really just a spontaneously cycling background. And each pattern has to last at least 10 seconds, and they have to be spontaneously alternating for at least 6 cycles. And they're usually a minute to several minutes each is kind of the typical cycle. And you'll see this rather commonly. And it's actually probably a pretty healthy sign as far as our critically ill EEG patients go. Most of them do well, and it's certainly much better than a non-variant or unreactive pattern. But there's virtually no literature on that yet. But hopefully now there will be. We defined voltage as well. The only thing added this time was that high voltage is greater than 150 microvolts. That means the general background is greater than 150. Continuity, this is how this one is defined. So it goes from continuous to completely suppressed. There's nearly continuous means 1 to 9% of the background is in this suppressed or attenuated state. And the only difference between attenuation or suppression is the amplitude, and we use 10 microvolts as the cutoff. And for all of these background cutoffs, that is in a longitude, not necessarily longitudinal, a bipolar montage using standard 1020 electrodes. When you're comparing voltage between 2 hemispheres, a reference is better. But for standardizing what a background voltage is, we did bipolar. Then that's basically because there's no single reference that you could pick that would be appropriate for that. Discontinuous means between 10 and 49% of the record is in this suppressed or attenuated state. And burst suppression means you're over 50%. Okay. Highly epileptiform burst, this did not change. This was already in the nomenclature. So for a burst, within burst suppression to be highly epileptiform, you had to have 2 or more epileptiform discharges in the majority of bursts, and they had to be occurring at an average of 1 hertz or faster within the bursts. It also could be present if you have a potentially ictal appearing pattern within the burst. So often the bursts aren't long enough to really qualify as evolving, but if it looks like it's trying to evolve, or would if you had more time, or if it's a burst of polyspikes, again, those all count as highly epileptiform bursts. And here's a schematic of that from the terminology paper, showing here's 2 sharp waves in, at least 2 sharp waves in the majority of bursts. And then here are some potentially ictal appearing patterns. We defined identical bursts as well. There's a paper or 2 on this suggesting that if you have identical bursts within burst suppression, that's an even worse outcome after cardiac arrest. And the definition only describes the first half second. So to have identical bursts, you have to have the first half second or longer of each burst looking visually similar in all channels. So the original papers were based on quantitative analysis, but now we're making it visual. So here's an example. The first half second is identical. It doesn't matter what happens after that. And then sometimes you'll see couplets. You'll see a burst of 2 different flavors of bursts come right after each other, sometimes even 3. As long as the first half second of the first burst always looks the same, that would qualify as identical. So here's an example of a highly epileptiform burst. And these are identical as well. You can see they're visually extremely similar in all the channels. Here's another example where they look extremely similar, but there's only 1 sharp wave in there for each one, so that does not qualify as highly epileptiform. So these are identical but non-highly epileptiform bursts. Reactivity, there's really no change in this. It just has to be brain activity. Appearance of muscle alone does not make it reactive. And any change in the EEG at all, in voltage or frequency or sudden attenuation, as long as it's the brain activity and it can be reproducibly shown to be related to any kind of alerting stimulus, that's known as reactive. If the only reactivity is SERPIDs, so whether it's seizures or periodic discharge or any of that, but there's no background, that's called SERPIDs only. It's probably an in-between in a prognostic standpoint between a reactive EEG and an unreactive one. It's certainly better than unreactive, but it's worse than normal reactivity. So am I allowed to stop and see if there's questions at this point? Let's see.
Yes, I will try to look at the...
I see one in the chat.
Yes.
There's misconception in regards to stimulus-induced seizures. Many don't believe in it. I don't know what there is to believe. So like the one I showed, it's an unequivocal electrographic seizure and an unequivocal clinical one. And it's actually quite common. In fact, when you test them well, probably somewhere near half of patients who have highly epileptiform patterns or seizures are going to be stimulus induced. And we pretty much treat them the same way as spontaneous ones. There's no reason to think a given pattern is any less or more harmful because it's induced by stimulation. So I use photoparoxysmal response as an example. So people have photic-induced convulsions. The convulsion itself is exactly the same as spontaneous ones, equally harmful and all of that. So yeah, in general, I treat them the same. The only difference is if patients have prominent stimulus-induced patterns and not at other times, sometimes we will treat before we have to stimulate the patient. So these are kind of in these long-term, mostly refractory, super refractory status patients, where every time you touch them, they go back into electrographic seizures, sometimes clinical with it. So for those people, we'll give them a bolus of some sedative before they have to get their nursing care, and we try to bundle nursing care. So we kind of call that the Serpent's protocol of nursing, where you stimulate as little as you have to, and you bundle it, and you give a bolus of propofol or something right before you do it. So yeah, I don't think there's much to believe in or not believe in. Whether stimulus-induced periodic discharges that last 30 seconds, whether you have to do anything about that is a different story. Usually the answer is no for that, because they obviously are spontaneously resolving. But I think there's no reason to think they're any different pathophysiologically or neuronal injury-wise. I don't know if there's any other questions in the
there
Q&A.
is one more in the Q&A section. What is the clinical significance of this new waveform, this CAPE? CAP?
Yeah, well, nobody knows because it wasn't defined or studied yet, but as I mentioned, I think it's actually a pretty good prognostic sign for our critically ill patients getting EEG. They tend to do well. I think it's a hint of normal activity. There is a big question of, is it related to cyclic alternating pattern of normal sleep, which it might be, but we really don't know because it wasn't defined. At least now it's defined. There's already, I know, 1 or 2 groups working on it. So we'll have some literature soon. So that's pretty much how this stuff works. We define the pattern and then people start studying it. Then we'll revise it and start learning what it means. But the first step is just to name it and define these things so people can study them. But that's another one. It's very common if you look at it, especially if you're using quantitative EEG. You'll notice a nice cyclic pattern or striped pattern to the quantitative EEG. And it's a common thing.
How do you deal with stimulus-induced flattening?
I don't deal with it at all. I certainly don't treat it as a seizure, but that's, at least it's a good sign that there's some reactivity. It's obviously not normal reactivity, but it's better than having an unreactive one. So we call that a reactive record. Okay. All right, let me move on to some of the other new things and we'll get back to questions. So these are the main changes in the new version. We added unilateral independent. That's the only change to the main terms. We got rid of this term variability. Nobody knew what it meant or how it related to reactivity and state changes. We just got rid of it. And now we added state changes instead. We added this CAPE that we talked about. We added stimulus terminated. We added the identical bursts. And then these other things that we'll talk about now are newly defined in the 2021 version. All right. Well, luckily, Shando already covered all this, so I can go very quickly through this. So electrographic seizure and electrographic status, it's really taken straight out of the Salzburg criteria. And it's very similar, the main difference being that electroclinical is separated out from electrographic. So for electrographic, it's just like you heard, it has to be greater than 2.5 hertz, greater or equal to 10 seconds. A lot of debate about whether to keep that 10 seconds or not. There was no consensus at all, so we kept it. That was our general mantra. If there was not wide consensus, we left things the way they were in the literature. So either greater than 2.5 hertz or definite evolution. And then status epilepticus was defined. It's really to match the ILAE. It's at least 10 continuous minutes. But this was a change. Actually, this wasn't defined at all before, but or greater than or equal to 20% of any hour. In general, people had been using 50%, including us in our papers. But we lowered that to 20% and put it in the nomenclature this time, largely based on one paper that I'll show you. So as Shandor mentioned, you have to count 10 seconds. That's the best way. I see people getting the frequency wrong all the time by saying, oh, I see 4 of them fit in 1 second, therefore it's 4 hertz. You know, that's just not right. People tend to say it's faster than it really is unless they count the full 10 seconds. So why this 20%? It mostly came from this paper which was in a pediatric ICU. And they looked at neurologic decline in these children. There was neurologic decline in 2/3 of them. It was a large study, 259 pediatric ICU patients. And they found that if the maximum hourly seizure burden was more than 20%, so which is 12 minutes, there was a marked rise in the chance and the severity of neurologic decline. So this is the paper showing the maximum hourly seizure burden and the percent of patients who had neurologic decline. You see no seizures, less than 20% maximum burden, and then over 20%, virtually all of the patients had neurologic decline. All right, there were one or two other papers in neonates showing the same thing, but there haven't been any. I've looked at that in adults, although seizure burden has been shown to correlate with outcome in several adult studies as well, but without a real clear cutoff like that. It's pretty much a dose response curve in kids and adults with seizure burden and outcome. All right, so then electroclinical seizure is defined as any EEG pattern. So this is different. It doesn't have to have epileptiform discharges. It doesn't have to be any particular frequency. So any EEG pattern that is time locked to a definite clinical correlate, and it can be a subtle one like thumb twitching as long as it's definite and time locked to the pattern, or EEG and clinical improvement with IV meds, and you heard all about that already. Okay, so this is part of why it was separated out is the actual EEG pattern. There's no particular criteria, so it could just be 1 Hertz high amplitude rhythmic delta. As long as there's a time locked clinical correlate, then that would qualify. Okay, I already mentioned that. And then to call it status, the same thing, more than 10 minutes or more than 20% of any 60-minute period of recording. And just remember that if it is convulsive, prominent bilateral motor activity, then you only need 5 minutes to qualify as status epilepticus. All right, so now on to the most difficult one, this ictal interictal continuum. So it's basically a synonym for possible electrographic status, and totally fine if you want to call it that, or for your impression, you just want to put that and forget this term. I have no problem with that, but this term has become widely used, including the literature. There's several reviews on this on the IIC, even though it hadn't been defined. So this is the first real definition of it. So in general, the concept is it's a pattern that does not quite qualify as electrographic seizures, but there's a reasonable chance that it's contributing to impaired alertness, causing other clinical symptoms, or contributing to neuronal injury. So it's potentially ictal in at least some way, and it usually or often warrants a diagnostic treatment trial, and that's typically with an IV medication. So here's the definition, and you'll see there's upper and lower frequency cutoffs for this. There were questions about that earlier. So any periodic discharge or spike wave pattern that is greater than 1 and less than or equal to 2.5. It can't be higher than that, or it's already definite seizure. So greater than 1, less than or equal to 2.5, lasts at least 10 seconds. Or it can be between 0.5 and 1 Hertz, including both ends. But in that case, it has to also have a plus modifier or fluctuation. So a 0.75 or 0.5 or 1 Hertz LPDs with a plus modifier or a fluctuation counts as being on the IIC. Or lateralized rhythmic delta that is greater than 1 Hertz that has a plus modifier or fluctuation. So that includes all of these patterns include some form of lateralized rhythmic delta activity. So bilateral independent, unilateral independent, multifocal, but generalized rhythmic delta is not on this at all. As far as we know, that has nothing to do with seizures. And then it's important to point out, to be on the IAC, you have to not qualify as definite seizures. If you qualify as definite seizure, it's just seizure. It's not IIC. So here's some examples. So this is one where the right hemisphere has these periodic discharges and some rhythmicity to it. It's one of those you wouldn't be sure which to call it, but it's somewhere around 1.5 hertz. So this is LPD plus R at 1.5 to 2 hertz. So this would be on the IIC. Here's a generalized version that's very similar, not fast enough to qualify as a definite seizure. So on the IIC, or you can also call it possible electrographic seizure if you prefer. And then possible electroclinical status, it's basically defined as a rhythmic or periodic pattern that's on the IIC for at least 10 continuous minutes or more than 20% of an hour that shows EEG improvement with a parenteral anti-seizure medication, but there's no clinical improvement, okay? So it's basically exactly what you heard and exactly what was in the Salzburg criteria for possible non-convulsive status. Okay, so anything on the IIC, it improves with your IV drug, but there's no clinical improvement. You're left not knowing if it's status or not. It's still possible. And again, just stressing that if it qualifies as definite seizure, then it's not in this category. Just some relevant literature using this terminology and including IV drug trials. I'll just mention 2 papers about GPDs with triphasic morphology. So this was actually the first ever real scientific study of these. Dr. Foreman sent these studies to 11 experts who blindly reviewed 20 continuous EEG studies that had generalized periodic discharges and found inter-rater agreement for triphasic waves was only fair, but for generalized and periodic, it was nearly perfect. And he found that patients who were felt to have triphasic morphology by these blinded readers who didn't know anything clinically, they actually had the exact same rate of seizures as those who were read as GPDs without triphasic morphology. And then the shocking finding was the ones who had triphasic waves were actually less likely in this group to have a toxic metabolic encephalopathy. It was very common in all the patients, but it was actually less common in those with triphasic waves. And then, so this was another study, a separate group that looked at the response to anticonvulsant trials in patients who had triphasic morphology in a pattern of uncertain significance. That was what the title said. And the response was defined just like you heard, positive response. You had to have not just the EEG pattern going away, but you had to have clinical improvement or a marked improvement in the background EEG. And some were benzodiazepines and others were these non-sedating drugs. And they gave the results separately. So there was a positive response in 19% of these who had benzo trials, but in a higher percent who had the non-sedating anti-epileptic drug. So they said 42% overall. 7% were immediate, 20% were delayed but definite, and then some were delayed and possible. So leaving those delayed and possible out, you still end up overall with 1/3 of the patients having a definite positive response. These are patients with generalized periodic discharges with triphasic morphology, getting an IV drug trial. 1/3 have a positive response, showing that it was actually non-convulsive status, or what they called an AED responsive condition. That pretty much means one of the reviewers wouldn't let them call it status just based on that. All right, let me move on to birds. Well, I suspect there'll be some questions about the prior topics, hopefully. So this BIRD stands for brief, potentially ictal rhythmic discharges. And there's really 2 papers came out. Dr. Yu has published both of those. She was at Yale. She was my fellow there. Is now at Mount Sinai in New York. So the original paper was all in the critically ill and found that, so defined it as a less than 10-second run of rhythmic activity had to be greater than 4 hertz. And it could be with or without evolution. It was usually sharply contoured theta and usually just a couple seconds long. And they found that 75% of these patients had electrographic seizures as well as their birds. And that was much more than a matched control group. And And the birds came before the first seizure in 14 out of 15 cases, meaning this might be something that alerts you that this patient is very, very high risk of seizures coming up. And then whenever seizures were successfully treated, the birds went away as well. Then it was also looked at in non-critically ill. So this was either in the epilepsy monitoring unit or outpatient ambulatory EEGs, and found that patients who had birds were more likely to be refractory, actually much more likely. So it seemed if you have birds, it seems to be a marker that your seizures are not well controlled. And then birds always came from the same place as seizures. And they suggested a definition that was basically became the ACNS one. And this is the ACNS definition of birds. So there's focal birds and there's generalized birds. It has to be greater than 4 hertz, and it has to last between 0.5 and 10 seconds. It can't be any known normal pattern or benign variant. It cannot be part of burst suppression or burst attenuation. It cannot have clinical correlate, or that would make it a seizure. And it has to have at least one of the following features. So either evolution, so that is a form of definite birds, or similar morphology and location as epileptiform discharges or seizures in the same patient. So you have to have seen those at another time in the record, but that's another form of definite birds. Or just sharply contoured, but without those, and we call those possible birds. So just some other points. So paroxysmal fast activity, focal or generalized, is now falls under this birds category. So the GPFA pattern would qualify as birds. And then the other point to realize is even though these are called brief, technically they're all very brief by the terminology because they're less than 10 seconds. But it was too hard to pronounce V-birds or the birds. So here's an example. Here is a bird. Here's another one. And these are some sporadic epileptiform discharges that are in the same location and morphology. So this is a form of definite birds. Here's one of my favorite pages showing 3 different ones. I usually play some Bob Marley music for 3 little birds on one page. Here's some other ones. So this is these are birds with some evolution. So these would be definite or evolving birds. Here's another one, much shorter, but still starts faster and gradually slows down. We qualify as evolving bird as well. And here's another nice example that shows sporadic discharges. And then you see a few of those, and then a bird, and then a seizure. It looks identical. You have to take my word for it that it goes on for more than 10 seconds. This is a pandemic joke slide about birds. This is a bird form of social distancing. All right, we're getting close to the end. This is an extreme delta brush. So this is defined as a subset of plus F, where you have to have abundant or continuous RDA plus F or PD plus F, but there's only one form of that, which I'll show you. It's down here, where the fast activity has a stereotype relationship to each delta wave. So here's the classic example. It's rhythmic delta, has to be continuous or abundant, and there's fast activity on it in a stereotyped relationship to the delta wave. So this would be definite extreme delta brush pattern. And here's the only way periodic discharges can qualify is if they're periodic blunt delta waves like this with the fast activity in a stereotype relationship again. So there's also possible EDB. So it's the same pattern, but it's only occasional or frequent. So it didn't make it to abundant. Or it's the same pattern, but the fast activity does not have a stereotype relationship. So I think that's much less specific. And now that it's defined, we're actually hoping to get some real studies on what this specificity is. It's clearly not that sensitive for anti-NMDA, and it's certainly suggestive of it, but it's not perfectly specific. but now we'll get some more literature. Here's just another example of extreme delta brush. Again, that's only true if this is a continuous or abundant pattern, but where you see this fast activity riding on top of each delta wave in a stereotyped fashion. Here's one from the original publication from Sarah Schmidt, and it does seem to be associated with worse prognosis within the anti-NMDA group. So the critical care terminology, the prior version, was subjected to multiple rounds of inter-rater agreement with some revisions. The final one, using the 2012 version, showed actually very good agreement for the main terms and most of the modifiers, not quite all of the modifiers. Agreement was substantial for some others, was only moderate for triphasic, and was pretty bad for evolution, but these were very short clips, so they weren't really designed to show evolution. So the conclusion was this is about as good as we're going to do, and you can use them for research now. So some things we've learned, people have studied the highly epileptiform bursts and shown if you have them when you're in burst suppression and you're treating status epilepticus, and then you wean the drug, most of the time they're going to go back into seizure. So 11 out of 17 times if you had highly epileptiform bursts. But if you did not have highly epileptiform bursts, all 16 attempts were successful for being weaned from the anesthetic. So here's an example of one patient in their study, a highly epileptiform burst, where they then failed the wean, and then later the same patient with a non-highly epileptiform burst successfully weaned. We've looked at lateralized rhythmic delta activity and shown that the rate of seizures is, at least in our hands, was identical to lateralized periodic discharges. I think that's because we only call it when it's very clearly rhythmic. I think some other people call rhythmic too often, and it's a little lower rate, but always a high rate with lateralized rhythmic delta. There's a high rate of seizures. Here's an example of lateralized rhythmic delta, and then at a separate time, a seizure evolving, faster frequencies coming from the exact location, and it's virtually always the same location. So this was the rate of seizures with lateralized rhythmic delta versus lateralized periodic discharges in the same cohort. This one included clinical seizures as well, and the second bar here is just electrographic seizures. There's been much larger studies. This was over 4,000 patients showing all the different patterns and how they relate to seizures. So there's a high rate with very high rate with LPDs at any frequency, but if the frequency within that pattern was higher, so 2 Hertz rather than 1 Hertz, the chance of seeing seizures went up even more. So for LERDA and GPDs, it only reached significant association with seizures when it hit 1.5 Hertz or faster. But again, most LERDA will be about 2 Hertz or 1.5 2 Hertz or faster, so it'll be in this category. And generalized rhythmic delta was not associated with seizures in this. As far as modifiers, they did seem to matter. Prevalence definitely matters. Higher prevalence, you'll see a higher rate of seizures. You see, for example, GPDs, when it's abundant or continuous, is a much higher rate of seizures than when it's only rare. Being stimulus induced did not seem to matter much either way. If you look at GPDs, it was the rate of seeing definite seizures was exactly the same on whether they were stimulus induced or not stimulus induced. And then, does it matter as far as prognostic significance? So this one, periodic discharges were associated with poor outcome. That's not surprising, but the interesting thing in this study, this is from Denmark a while ago now, they looked at some of the modifiers, and they found that LPDs plus was associated with a higher risk for later epilepsy than LPDs alone, and it was significant. And a pattern being continuous or abundant was associated with worse outcome than if it was frequent or occasional, and the duration also mattered. So the plus with the prevalence and the duration all seem to be associated with prognosis. So in conclusions, we have an ACNS guideline on terminology, including the background. There's a separate neonatal version. Many terms are now defined, including some new ones. Many have at least some scientific evidence about them now, but many do not, perhaps most do not. And probably all of them have not been adequately studied as far as how we should manage them. The expanded version includes definitions of seizures, status, birds, the ictal-interictal continuum, identical bursts. It's all available on acns.org. It comes with a reference chart, an abbreviated version, things you can hang up in your lab, and many more EEG examples than I've shown you here. So with that, I will stop and happy to take more questions.
Thank you, Dr. Hirsch. That was an excellent talk for such a complicated issue. I have some questions here. One is from Kaona Suchano. Dr. Suchano says that, let's say that we have a patient with time lock jerking with abnormal EEG, and after 30 seconds, midazolam 5 milligram IV administration, the jerks are subsided and the EEG shows suppression for 5 minutes. Can I say this is electroclinical seizure?
Well, you could have already without the drug trial because they had time-locked jerking. So that's enough to qualify as electroclinical seizure. So even if this drug trial failed, you could. I thought the question was going to be the jerks go away, but the EEG pattern is still there after. That's a more difficult one. So we see that a lot. Something that, maybe it's 1 hertz, but they're twitching with each one. That's electroclinical status. And then sometimes you give a benzo, the pattern doesn't change much or becomes a little lower amplitude, and the twitching's gone. So you're left with a pattern that's 1 hertz periodic discharge with no clinical correlate. Of course, it looks very similar to what used to have a clinical correlate. So that gets a little tricky, but you'd have to just describe the pattern then. It might be on the IAC, might not, but yeah, so this one, yes, that was an electroclinical seizure.
And then a follow-up question, it's from YouTube streaming. Somebody is asking whether you can treat, or you want to treat this IIC.
Yeah, so that's a very individualized issue and depends on the full picture, how fast it is. I can tell you in general, if I had to, just lump everybody, if a pattern gets to 2 hertz or faster, I usually treat them. And that's largely based partly on clinical experience, partly on the data showing that 2 hertz or faster periodic discharges seem to be associated with neuronal stress and really with tissue hypoxia when you're doing invasive monitoring. So that's the paper that came out of Jens Vich and Jans Klassen's group at Columbia with invasive monitoring showing 2 hertz discharges were associated with brain parenchyma hypoxia. So yeah, in general, 2 hertz or more, I'm gonna treat. Slower, I'm not. But you really need to look at the big picture, and those are tough questions. We often use ancillary things like their imaging. If there's restricted diffusion on imaging, serial neuron-specific enolase, blood flow, or PET scans can also help you to see if the physiology is like that of seizures, which might push you a little more to treating.
But will you treat this pattern as a status epilepticus, or you will just give it a trial for anti-epileptic?
Right. Oh yeah. So I have a pretty low threshold for doing a trial, and
Okay.
If you can show a positive response, then it's status epilepticus and treat it as such. If it comes out equivocal, or you end up with possible status, which often happens, then it's a tough choice. Sometimes we'll leave the seizure medication on. Usually they're on at least one thing for us, but a non-sedating one. But I do not usually add something that's coma-inducing for an equivocal pattern like that. So we'll add on non-sedating ones. We'll increase their levetiracetam or lacosamide a little, but no, we will not give coma-inducing meds for equivocal ones.
I think we will stop here and thank Larry for starting out early today. We will then go on to the next speaker, talking about the treatment of patients in a non-convulsive status epilepticus. We have asked Associate Professor Jakob Christensen from the Department of Neurology at Aarhus University Hospital to help us out here. Please, Jakob.
Thank you very much. I'm just going to try and find my presentation here. All right. I hope you can see my screen now. Thank you very much for this kind invitation to talk and to try and address some of the findings that we've discussed this afternoon. And yeah, well, I'm an associate professor at Aarhus University Hospital and working with a lot of the people here that has presented earlier. So first, my disclosures. I worked mainly as a PI on clinical trials on a number of studies and worked with support from the Danish Epilepsy Association and the Novo Nordisk Foundation. So there are a number of issues that I would like to address in this talk. First of all, when to treat. We've discussed that early on, and Eugen touched upon this early on, but I'll continue a bit of discussion on what to do. Then the next issue is what to use, what kinds of drugs to use. Next thing is what dose to choose, and finally what to do when it fails. So first of all, when to treat. So basically there are different strategies to choose. First, there is the aggressive approach to treatment, depending a little bit on the experience of the person actually that sees the patient. The other approach is what I call non-aggressive, and often it's a balance between these two approaches to treatment. And I'll exemplify a bit of about what I mean with these two approaches. So the one approach is once we get the assessment from the neurophysiology, for example, is that this could potentially be the status epilepticus, then we will start and use a lot of anti-seizure medications, and we will go on with intubation and anesthetics. And the reason for this is this grave consequences of continuous seizures that is very harmful to the patient's brain. That we know that if you have ongoing seizures, this could potentially be the outcome. And it's really devastating to see patients with these severe symptoms after a prolonged seizure period. So that's really what we fear, and that leads us to really throw all we have of drugs towards these patients once we see this. The other approach was the non-aggressive, and we may take that path because we know that there are so many other factors in non-convulsive status epilepticus that are important for the final outcome. So we know, of course, seizures is part of it, but we also know that the underlying cause is important. And why is this important? This is because once we intubate the patients and put them into anesthetics, everything stops. We are unable as a neurologist to actually assess anything. We get no help from neurophysiology. We get no help from our reflex hammers or our test of reflexes. We are, so to speak, blind. And we may miss important underlying causes. And I'm just taking as, for example, here, an underlying causes that could be a sinus thrombosis causing seizures, causing significant mortality that could have been otherwise avoided if we had continued monitoring and evaluating that person. And we know that it's hard from clinical point of view to pick up a sinus thrombosis. It's hard to pick up on clinical examinations. It's hard to pick on neuroradiology, or it can easily be missed if you're not very specific in your suspicion and you're not in close collaboration with your neuroradiology department, because they earlier, well, here it's quite evident, but early on in the course of the disease, it may not be as evident as here. So you need to balance these two approaches with the very aggressive and the non-aggressive approach. So it is really a collaboration between departments. So you really need to work with intensive care, you need to work with neurophysiology, you need to work with radiology and neurology. And what is important here is that the guys that we actually send out in the field to take care of these, at least from in terms of neurology, is that these are the young persons. They will see them in the acute setting. We know the mortality there is high. They are unexperienced. They are non-specialists. We know that early initiation of treatment will favor outcome, but we also know that if we give those guys in the front line some guidance, we will know that this will improve the outcome. The next question was what to use. I will focus a little bit on the basic treatment, and the reason why I will focus on the basic treatment is that this is the most prevalent cause of mismanagement of these. It's not the very, very rare causes of non-convulsive seizures. It is actually mismanagement early on of non-convulsive status epilepticus. And the main treatment early on is benzodiazepines. And the main way of actually applying this drug is via the intravenous route. The benefit of benzodiazepines, and we discussed this early on today, is that it's highly lipophilic. It means that it crosses the blood-brain barrier very quickly, goes into the brain, and acts very quickly, much quicker than any other drug like levetiracetam, phenytoin, or valproate. It's much quicker. So where does the evidence come from? So this is a randomized trial, quite old randomized trials, but it's relevant because it actually includes a placebo group. So what they did was they looked at out-of-hospital status epilepticus. It was convulsive status epilepticus, defined as seizures with a duration of more than 5 minutes. And then they were randomized to either placebo, diazepam 5 milligram, or lorazepam 2 milligrams, and this could be repeated once if needed. And the outcome was whether or not seizure was stopped at arrival to the hospital. And what we saw was that lorazepam was actually the most efficacious, followed by diazepam, and then placebo. So treatment with benzodiazepam had an effect. Lorazepam seemed to be superior than diazepam in absolute terms, but the estimates were not statistically significant. What about respiratory complications? We always fear that when we give benzodiazepines, we will have a fear of respiratory or circulatory complications. But actually, that was much more prevalent in the group that you you gave placebo. So continuous seizure is a greater risk of respiratory circulatory complications than treatment with benzodiazepine. However, should things go wrong and you are in the hospital setting, here's what you do. Of course, you can ventilate outside hospital also, and that is often the case. But you have a way out if you feel that the patient is suffering from your treatment with benzodiazepine, or you can apply antidotes like flumazenil that will revert the effect quickly of the benzodiazepine. So you have a treatment that is efficacious, quick, and will show you result early on. What if we do not have IV access? Are there other routes available? Yeah, you know, of course, that there are rectal diazepam available, and this is a study of rectal diazepam versus buccal midazolam, and this was done in a setting of children. And you are familiar with a lot of additional studies that studies various combinations of rectal diazepam, buccal midazolam, intranasal midazolam, and so on. There's a lot of studies, but this was one of the first studies that actually compared these application methods. So buccal midazolam giving in the mouth, in the chin, so the person will not swallow it, but it's taken up via the plexus, the venous plexus here in the buccal cavity, and the idea is here that the drainage here is via the jugular vein, so it bypasses the first pass metabolism and goes directly into the circulation and into the brain. So straightforward. The same with rectal diazepam. Again, what is essential here to understand is that the venous plexus here around the distal part of the rectum is actually draining into the systemic circulation, so it bypasses again the liver and goes directly into the brain. So maybe contrary to what you would expect, this also bypasses the liver and gains access to the brain. So what did the study show? Well, the primary outcome was cessation of seizures without respiratory depression, and the primary outcome was again midazolam slightly better than diazepam, not significant, and respiratory depression similar in the two cases. So if anything, midazolam giving buccally does not seem to be working worse than rectal diazepam. So that has, at least in Denmark, meant that more and more people are treated now with midazolam, that for a lot of other reasons, it's a much better option for persons with epilepsy who suffer unexpected seizures. So conclusions on the benzodiazepines: use IV benzodiazepines if benzodiazepines if you have IV access. In Denmark, it's diazepam, which is available across all emergency departments. It could be any other benzodiazepam or benzodiazepine, like for example midazolam or clonazepam. But for historical reasons, diazepam is used in Denmark. It's very lipophilic, goes into the brain. Or you could consider other ways of administration if you do not have IV access. That could be buccal, or it could be rectal, similar doses of the two drugs, midazolam and diazepam. So that is basically what is at least used in Denmark and in many countries worldwide. So in hospital treatment, so we finally have this the results of this essential study from the United States, mainly that compares the three interesting drugs that are used for acute convulsive seizures. And the reason why this is interesting here with non-convulsive seizures is that we mainly rely on the results of this study for the treatment of non-convulsive status epilepticus. So here are the results. They compared 3 different drugs: levetiracetam, fosphenytoin, and valproate, which were at the time of the planning of the study the 3 relevant options for treating convulsive status epilepticus. And you know that the efficacy and the side effect profile were similar across the 3 drugs used. So this was the efficacy of this. So there are some things that needs a little bit of specific attention. So you're well aware that fosphenytoin, at least in Denmark, has replaced phenytoin because of the ease of applying the intravenous medication. So you can apply this by pH around 8 to 9, whereas you would have to give a phenytoin with a very high pH and all the problems that this would cause. And the reason for this is that the company added this phosphate molecule that makes the phenytoin soluble, and then once it enters the systemic circulation, this phosphate is no longer, it disassociates from fosphenytoin, and then you're left with the phenytoin drug. However, the dosing is difficult here, because we talk about fosphenytoin equivalents, and the 50 milligrams of fosphenytoin equivalents is different from the actually content, which is the fosphenytoin. So this will always cause confusion, and I actually think I mixed it up also today. But it means that, again, we will need guidelines. We will need specific instructions for how to treat these patients. Make sure that your nurses are 100% sure of what dose you will give if you treat with phenytoin, because this is complicated to administer. So again, there's a need for guidelines. It cannot be said often enough. All right. So what dose? Well, this is where I actually would like to involve you as participants and ask you what actually determines the loading dose. So the loading dose depends on weight, liver function, renal function, or height. And yes, we've been given the answer here. The weight is the only thing that determines the loading dose. So don't think, just weigh the patient or ask the intensive care person to estimate the weight. They do this every day. Ask them what is the weight of this patient, and then you determine the loading dose of the medication. So the only thing you need to know is the weight of the patient. Then you have then once you've administered the loading dose, you need to determine what is the maintenance dose. And does this then depend on the weight, the liver function, the renal function, or the height? Well, it is actually the liver function or the renal function, depending on the metabolism of that drug. So, for example, if it's levetiracetam, who's only metabolized or excreted via the kidneys, it will depend, the maintenance dose will depend on the renal function. But the loading dose does not depend on the renal function, not even for levetiracetam. So, what loading dose do we choose? So, here the trials, here's the trial on convulsive status, where we used 60 milligrams per kilo for levetiracetam, 20 milligrams per kilo for fosphenytoin and 40 milligrams per kilo for valproate. Actually, it's suggested to use slightly lower doses for non-convulsive status epilepticus. And that is because we would like not to influence the patient too much from the drugs. So we will have a clearer picture of the efficacy of the drug. And then we can always add a little bit extra if it's insufficient. But make sure that at least you give an efficacious dose. Don't start with very, very low doses. Give something like this a relevant dose that you would, if you give this, you would expect to see a response either clinically or on the EEG. So this is when benzodiazepine doesn't work. Start with one of these 3 drugs. The benefit of this, the benefit of choosing one of these 3 drugs is that your unexperienced associates at the hospital will be very familiar with these 3 drugs and how to administer them. There are a few new options that may be relevant at your hospital depending on availability, and one of them is lacosamide. And I've just included one trial that actually looked at non-convulsive status epilepticus in the critically ill patients. So it's a little bit different than the overall group of non-convulsive status epilepticus. And what they did was they randomized persons to fosphenytoin, like 20 milligrams per kilo. So that would be the treatment that you usually give to convulsive status epilepticus, and a relatively high dose of lacosamide, 400 milligrams. And so here's the primary outcome was the absence of electrographic seizures for 24 hours. And that was actually achieved in 63% of the subjects that were randomized to lacosamide and 50% of the subjects with fosphenytoin. So this difference was not significant, but it tells you that maybe lacosamide does not seem to do worse than fosphenytoin. So it may be a relevant alternative to treatment with fosphenytoin. Similarly, with the side effects, that was similar in the 2 groups. So here the well-known treatments, and here is a potential new drug that you could administer for your patients. So once you're given the loading dose, remember the maintenance treatment after loading. And you may then wonder, I've given this loading dose, I want to change to oral formulation of these drugs. And all these drugs are, of course, found in an oral formulation, and you wonder, how do I convert? So how do you convert from IV to an oral dose? Is it 1-to-1? Is it 1-to-2? Is it 1-to-3? Is it 1-to-4? And it's actually 1-to-1 for all of them. So it's very easy to remember. Just use the exactly same dose that you have decided to use as a maintenance dose. Once you go over to oral dose, then just change it 1-to-1. All of these 4 drugs that I've just mentioned have a 100% absorption from the from per-oral administration. So that will make sure that let's say, for example, the patient has an nasogastric shunt, then you can apply the medication via that way. So there are a few additional things that I would like to mention with regards to each of the 3 major drugs: phenytoin, levetiracetam, and valproate. So phenytoin is a particular concern, and I mentioned one of the reasons. One of the reasons was the difficulties about the fosphenytoin, but another thing relates to the pharmacokinetics. Usually we have what we call linear pharmacokinetics, meaning that once we double dose, we also double the plasma concentration. And that makes it easier for us to adjust the concentration of the medication during treatment. And that is particularly important here when you have acute treatment and you would like to monitor over time. However, for phenytoin, we have zero-order pharmacokinetics or zero-order elimination, meaning that once you increase dose just a little bit, the therapeutic in the therapeutic range, the concentration will increase disproportionately. So you will risk intoxication of the patient just increasing the dose a little bit. So you have to bear that in mind, that within this therapeutic range, you will have zero-order elimination. So you overcome the body's ability to actually excrete phenytoin. Another issue that you need to be aware of is the regulation and transport across the blood-brain barrier. See, in the plasma, drugs are bound to protein or they are free. And mainly for drugs like valproate and phenytoin, the main part is bound to protein. And what actually goes across the blood-brain barrier is the free fraction. Inside the, or on the other side of the blood-brain barrier, in the cerebrospinal fluid, the protein level is very, very low. So the free fraction in the plasma is actually identical to the free fraction inside, on the other side of the blood-brain barrier, and that is the fraction that will actually achieve seizure control eventually. However, when you measure plasma concentrations, you get the total concentration. So the concentration of the drug bound to protein and the free concentration. So if you have a patient with very low protein, then the distribution will still be the same, but then the relative contribution from the free fraction will be larger. So you need to take that account if the protein level is very low in a person. Okay, so a low concentration of protein will give a relatively high free fraction of the drug, the effective one. So if you adjust based on the total, you will need to take that take that into account. So lower levels will be more effective in a person with low plasma protein levels. Valproate, there are specific. So basically, the metabolism of valproate is straightforward. There are linear kinetics, except from certain conditions, and we do not have a very good explanation for that. Meropenem, an antibiotic that is often used in very sick persons, has a profound effect on the concentration of valproate. And as shown here in an acute patient, we have a patient who was admitted to hospital and giving meropenem. And as you can see here, the drug concentration of valproate decreased sharply, resulting in seizures. And this has been replicated in a number of case studies and is well described in literature, but we actually do not know precisely why this happens. But it's well described, and you must take this into account if you use the valproate for treatment. Levetiracetam, very easy drug to use, and the reason why this is easy to use pharmacokinetically is that it's only excreted via the kidneys. So so this is nice and easy. It's not metabolized to any important extent via other enzyme systems. So you do not have to take interactions into account. This makes this a perfect drug for let's say old people or people who have many kinds of treatments, and you will see that the use of this drug has increased sharply. However, if you have problems with your kidneys, you need to adjust the dose. Okay, this is well described. It's very easy, but you just have to remember, otherwise you will intoxicate the patient And this may be misinterpreted as drowsiness or maybe even non-convulsive seizures if you do not have access to EEG monitoring of the person. So you will actually see that if you think that that this person has non-convulsive seizures, if you're not able to monitor it, you're actually intoxicating the person with severe renal failure. But just adjust according to this algorithm and you'll be fine. I've added this Danish link to the Pro Medicine that describes this in detail. Very easy to use, just remember to adjust. Also remember this in the very final part of the person's life, when they are terminal. If they stop drinking or producing urine, they will accumulate this drug and effectively also be intoxicated if you're not careful. So what if this fails? So you have to be very careful to use the benzodiazepine correctly, use the loading dose correctly, and if you do that, you will actually be fine in many cases. But you also need to address other things. And of course, if this fails, what do? We do what we always do. We call on the people from the intensive care unit to come and help us. But they will need some instructions on what to do. And this is where we need some guidance from further studies, and we do not have very good guidance here. So we will now need to induce general anesthesia if we are certain on the diagnosis, and we have sufficient workup to be sure or reasonably sure that we are not missing any underlying cause. And here are the treatment options: midazolam, propofol, ketamine, and pentobarbital. Whether you use one or the other will actually depend more on the intensive care unit and their experience. So, for example, in Aarhus, where we live, propofol is very widely used because it has such a short half-life, so they can give it and easily taper off the treatment again. So that's very easy for the intensive care unit. However, if you have patients that continue to need to be sedated over days, this may not be the best option. So you start combining. You start combining with midazolam. You start combining with ketamine and maybe pentobarbital. And this is where you really need to work closely with neurophysiology. How much is actually needed to obtain sufficient sedation, to burst suppression at least, to make sure that this patient is treated optimally. So you need to work it. There are no easy way to do this. You will have to decide with the intensive care unit what they use. So it will depend on other things. Are the persons responsive to propofol, or do that person need extremely high propofol doses that may interfere with maybe muscle enzymes that certainly starts increasing, and you would need to switch to some of the other drugs. So here, the dosages here are taken from UpToDate, so they are merely suggestions on what to use. They will be highly individual dosages. So the people in the intensive care unit will have to adjust this based on your input from the neurophysiology, your clinical input, and what you would like to do in terms of follow-up and maybe clinical workup to identify the cause. So what is better? It's as you can understand, very individual. So there are no trials, there are no consensus. There are lots of opinions on what to use, and it's based very much on the individual clinician's experience. And this is always a bit dangerous, but it's not dangerous in the terms that if you rely on the experience of the intensive care unit and they more or less follow algorithms here and induce anesthesia onto burst suppression, then you will, I think you will be relatively fine. All right. So in conclusion, when to treat? Aggressive, non-aggressive depends very much on the level of non-convulsive status. Eugen Trinka talked about the comatose versus the non-comatose, and the level of underlying brain disorders, and that helps you determine how aggressive you will be. So if there's no major underlying neurological disorders, you will tend to be more aggressive. But please remember that your young doctors will tend to be very aggressive. So they will tend to say, okay, I will not miss this non-convulsive status epilepticus. I'll better treat. And by doing this, they may miss the course of the non-convulsive status epilepticus. So this is where we all need to pay attention, is when a young doctor comes and says, I've tried it and I've treated this person for non-convulsive status epilepticus. You really have to go through all the potential causes of non-convulsive status epilepticus to make sure that you are not missing an underlying cause. So what to use? Benzo. Use benzodiazepines followed by anti-seizure medication and then general anesthesia. Follow the timeline, 10 minutes, 60 minutes. You have to go into general anesthesia within roughly an hour, maybe longer for absence status, but absence status is not really a major concern in refractory and non-convulsive status epilepticus, but because once you hooked up the persons with non-convulsive status epilepticus of absence types, you will realize quickly what it is, and you will direct your treatment after that. What dose? Well, same but different, slightly lower, but same algorithms. Use the drugs that the persons usually use, but use it maybe in a lower dose to make sure that you are not interfering with the assessment of the person with non-convulsive status. And then finally, look for underlying causes. Keep looking for underlying causes. And this is when you think you're done and you've tried everything, that is where you go into experimental treatment. We touched upon corticosteroids and other ways of treating non-convulsive status. But that's when you're beyond the point of looking for underlying causes. So just a final note, non-convulsive status epilepticus that needs an expert opinion. Don't do this alone. You need the input from other departments, other specialists to do this sufficiently. Thank you very much. Yep.
Thank you very much, Jakob, for this comprehensive talk. We have questions. I'll start with Dr. Fabricius. He is stating that in his experience from continuous EEG, after standard loading dose of phosphonitrin, maintenance is not enough to keep the patient out of status. Another half loading dose is very often required. Do you have any comments on that?
Yeah, it depends a little bit on the dose. So if we've discussed, at least here in Denmark, what would be the maximal dose. If you follow the guidelines from the randomized trial, then they actually have a maximum dose and you hit that maximum dose if you weigh over 75 kilos. So we actually decided not to have a maximum dose of the drugs used. So it may be that if you have a maximum dose, you give it an insufficient dose early on. But at least in Aarhus, where I work, we can easily get measurements of phenytoin within. This is an acute test, so you can get this measurement quite, and you can then you can add a supplementary dose. Yeah. We are not as fortunate as you in Copenhagen that you have continuous monitoring of the at least not during the 24 hours. So it's not always that we actually see or realize that we are treating the patient insufficiently.
Yes, thank you. Dr. Benitsky has asked about what about intramuscular midazolam versus intramuscular lorazepam?
Yeah, so basically both methods are relevant, but both drugs are lipophilic, so it'll be but the duration, duration of the two drugs may be slightly different, so the efficacy may be slightly more longer lasting than if you gave diazepam. Diazepam is probably the fastest acting of the drugs. On the other hand, midazolam, for example, has more sedative effects than diazepam. So you will often realize or see that the patient actually falls asleep. And if that is misinterpreted as respiratory insufficiency, you would often see that the people in intensive care or the emergency department will intubate the patient. And that is not always to the benefit of the patient.
Yes, thank you. Dr. Blaschow is asking whether there is a max loading dose for levetiracetam. Should we, for example, give 6 grams to a patient who weighs 100 kilogram?
Well, that would be the logical things to do, given the fact that this is. But the maximum dose in the controlled trials were based on 75 kilos, so that would be 4,500 milligrams. So if you are very strict and you want to base your algorithm on trials and those are then you should not exceed 4,500 milligrams. I think that's probably a fair dose to start with in non-convulsive status epilepticus, but in convulsive, I think I would go higher with the initial dose.
Yes, and Dr. Cruz is asking whether you can comment on how the concomitant use of ketogenic diet can affect the pharmacokinetics of anti-epileptic drugs used in status.
So personally, I don't have much experience with this. But theoretically, it can interfere with the absorption of the drugs. But if anything, it may lower the absorption of the drugs. But I'm not updated on that. I'm sorry. But I would say that we actually rarely end up in a case where we would consider ketogenic diet, but I think we often manage without. Yeah.
Yes, and Dr. Cruz is following up with a question. Can you comment on how you adjust your treatment approach when you're dealing with a patient in focal status epilepticus?
Yeah, so in let's say focal status epilepticus, where you have continuous seizures, but so focal, I assume that this is you can have it with affected awareness or without, and I would say that this is where you are giving much more room to try other drugs, for example. So if you have, let's say, typically it will be let's say a tumor, a glioblastoma, for example, where you have continuous seizures, and you would you would rather that that person does not end in ICU intubated. Then you would try other drugs. That you would definitely try and aim for something that you would continue working with as well. And that's where you're given much more room, because you can give it then via, for example, a nasogastric pathway, or you can give it orally. But there you're actually able to give like topiramate or whatever, depending on the choice.
Yes, we have another question from Dr. Paula. This is about the usage of ketamine. Do you use intracranial monitoring, or how do you do it? And then she's congratulating on your presentation. But yeah.
Well, thank you. Well, yeah, we would usually start with propofol at midazolam, and if that doesn't work, we will switch to ketamine, and we will aim for monitoring. So if possible, we will try and aim for burst suppression, similarly to the other situations, and then go from there. But we will make sure that we have sufficient sedation of the patient, even with ketamine. And ketamine has these theoretically advanced, because it interferes with glutamate transmission, that gives you some theoretically advance over some of the other drugs, because maybe you can avoid some excitotoxicity that actually stems from the continuous seizures. But because we lack these comparative studies, we do not know whether this is actually the case also in humans.
I think there was also a question before about whether you monitor intracranially. I mean, with the intracranial.
No, so intracranially. No, we don't.
No, we don't. Yes, and there is another question. As far as I understood from Professor Trinka overview, phenobarbital is still second to none in controlling SE. Why it is used and recommended that sparsely? Is that because of acute toxicity and long half-life?
Yeah. So in our setting, the main indication is actually alcohol withdrawal seizures. If that for some reason continues, we often see that the patients will discharge themselves once they realize that they're in hospital and they wake up. So that because phenobarbital actually has such a long half-life, you can actually try and make sure that the patient actually is somehow have some benefit of the drug after discharge from the hospital. But otherwise, it is mainly because of the sedative effects of the anti-seizure medication. You would rather see that, let's say, for example, you give phenytoin, it's not so sedating, and you would like to see the patient wake up from this non-convulsive status epilepticus. So I think that's the reason why most people do not use it as first-line anti-seizure medication. But you're probably right. It is probably very effective in terms of reducing that. But as I try to explain, we would like to see the patients come back into out of this this non-convulsive status, and then see a clear person. And if you are worried that there is still some sedation left from phenobarbital, then you'll make you reluctant to use that kind of treatment.
Yes, thank you. There is another question from. Just a minute. Another. Is there any different choice of antiepileptic for different subtypes of non-convulsive status?
Yeah. So benzodiazepine works on everything. So you can use that. So the start of this is always the same. benzos, whatever is the local preference. Once you've established that this is absence, non-convulsive status epilepticus of the absence type, you should not use phenytoin, for example. You probably should use valproate, and if you have a young woman and you're worried that that person is pregnant, you can use divitastam. That would be my approach to it. But absence status is very rare, so it will mainly be focal status epilepticus, non-convulsive status epilepticus, and there you are left with the three options, and I'm not sure anyone can tell you which is better of these three options. Lacosamide may be as good as the others, but I would certainly choose valproate, phenytoin, or levetiracetam, because this is the core treatment now. So my junior doctors will be familiar with treatment.
Yes, following up on that, Dr. Sidaros is also commenting, saying, wouldn't it make sense to differentiate between different subgroups of non-convulsive status when deciding on the aggressiveness of treatment, whether status developed from convulsive status or not, or whether the patient is comatose or not, or whether the EEG shows definite or probable non-convulsive status? I think there is a risk of undertreatment. And at least this is what we have seen. This is Dr. Sidaros' experience regarding the comatose patients. Yeah.
Yeah. So this this very much speaks into this. So this is not something that you do alone. You discuss this with your neurophysiology department, and you actually because often the history that you get in the emergency department is insufficient. So you're not able to say, so this person is found at home, maybe. So you don't know whether this is a continuation of a generalized tonic-clonic seizure or some other condition, some underlying CNS infection or whatever. So you need to do the workup on the same time as you decide on treatment, and you try and involve the information from the neurophysiology and sometimes neurophysiology is able to help you with dividing into these, whether this is likely some comatose non-convulsive status epilepticus that is likely to be secondary to a generalized tonic-clonic seizures. But that is far from always the case, especially because many of these patients will actually enter the emergency department out of hours, where at least here in Aarhus we are not able to monitor. And also it will take the emergency department some time to actually realize what is happening.
Yes, and then I'll end with one last question. Dr. Nadziha is in an area with limited resources and is asking whether starting with anesthesia after benzodiazepine prevent the structural damage resulting from status, non-convulsive status.
Yeah, so that is a trade-off. As mentioned before, as a neurologist, you lose your ability to actually do some reasonable workup clinically once you and put the person into anesthesia. So that you will have to be very careful with that approach. But we actually see it in Aarhus also that the intensive care persons are just jumping over the treatment with the anti-seizure medication because it's easier and it's faster. And sometimes it's a good choice because it stops the seizure, and sometimes it's a poor choice because we miss an important underlying condition. And that's where you really need to be sure that your emergency physicians actually call the neurologist to have an assessment and try to figure out what would be the best approach. I would say resource poor countries, I would assume that it would be more likely to have anti-seizure medication available. These are I mean, Levitas, tamifenitoin, and valproate, at least one of them should be available, or phenobarbital.
There is one last question just popped up. Do you have some experiences with perampanel in non-convulsive status?
No, not personally. No, we do not have it for intravenous treatment, and I haven't. I mean, sporadically I've tried it in not in convulsive, not in status, but work with frequent seizures, but nothing that is very striking. No.
Yes, and there is the last comment. Thanks for an excellent presentation.
Thank you.
Yes, thank you very much, Jakob, for bringing this live event to a conclusion. I would like, on behalf of the Danish Society of Clinical Neurophysiology, to thank all the speakers for their contributions and bettering our understanding and the clinical knowledge of this important topic. I would also like especially to bring my thanks to Shandor and Erisela for making the planning of this event, and of course also like to thank the participants for participating in such high numbers. We will end this live event now. Have a pleasant evening.
Thank you. Bye-bye.
Bye-bye. Thank you.